So I request all of you to mute your mics for the time being. We are starting the meeting.
Very good evening to all. Warm welcome to Indian Cardiology Summit 2021. This summit is planned as 3 days virtual educative meeting with lectures from eminent speakers from across the globe and live cases on each day. I'm Dr. Shafeeq Mattummal, Consultant and Chief of Cardiology in Astromims here in Calicut, Kerala. In the 3 days from today, we have arranged sessions with advanced topics in interventional cardiology ranging from imaging for plaque progression through the latest in calcium ablation therapy to the most of scientific evidences in TAVI and other structural interventions. We have designed each day's session with a dedicated course director to bring the best of learning from all faculties from the live cases as well as the lectures. Today, on the first day of the summit, we have none other than Professor Bahuleyan sir as the course director in imaging session. Dr. C.G. Bahuleyan is an eminent and well-known cardiologist with more than 27 years of experience as an interventional cardiologist. He's working currently as a chairman and chief of interventional cardiology in Anantapuri Heart Institute, Trivandrum, Kerala. He's been a master teacher and has many years of experience in various medical colleges in the state. He's one of the authorities of imaging and physiology in India and is the founder president of Society of Coronary Intervention and Physiology. Over to you, Bahuleyan sir, and a warm welcome to all of you once again. Thank you.
Hello. Dr. Bahuleyan sir, you'll have to unmute yourself, please.
Okay, so we have imaging session today, and we are waiting for Dr. Bahuleyan sir to log in and give the introduction to how the day is going to roll out. And after initial session comprising of 2 talks, we have a live case coming from NIMS Trivandrum, and after that another 2 sessions in various topics in imaging in cardiology, in various aspects of coronary situations. And Dr. Bahuleyan sir, can you hear me?
No, he's only joined.
All right, so we'll wait for him. In the panel, we have an eminent panel here. Dr. Salman, would you like to introduce the panelists, please?
Okay, let's go with this picture. And cameras, both cameras.
Hi, good evening to everyone. Thank you, Dr. Shafeeq. I'm Dr. Salman Salahuddin. I'll take over the role as moderator for today. We indeed have an exciting and jam-packed session of talks today in intervention, imaging in intervention cardiology. Right. So, first session, I think Professor Bahuleyan sir, who's our course director for today, has got a small technical glitch. He'll be joining us soon.
I'm just getting in.
Right. Okay. So, before he joins in, I'll just give a wrap up. We'll be having our first 2 expert talks, which will be chaired by 4 eminent faculties. The first session would be on coronary imaging. The whole session today is on coronary imaging. As Dr. Shafeeq mentioned, we have jam-packed a lot of eminent national as well as international faculties, all for all 3 days coming starting from today. I would like to hand over to Professor Bahuleyan sir, our course director for the imaging session today, to give his opening remarks. Over to you, Bahuleyan.
Thank you, Shafeeq. Thank you, Shafeeq, very much. I'm so happy that I took part of this wonderful program. We have, as you mentioned, that this is a focused session on imagiology, first day of the program. We have 4 sessions, out of which 1 session is a live case, and the other 3 sessions are topics on various aspects of imaging and coronary intervention. We have 2 international speakers and 4 national speakers. Let us start the program straight away. I'm leaving on to Dr. Salman to moderate the session. Dr. Salman, please.
Thank you very much, sir. Thank you very much, sir. We'll go ahead right away and kickstart today's program. For the first session, we have 4 expert panelists. I'd like to introduce Dr. Sridhar Kasturi, Senior Consultant Cardiologist from Sunshine Hospital, Hyderabad. We have with us Padma Shri Dr. Balbir Singh, sir, from Max Hospital, Saket, Delhi. We have Padma Shri Dr. Praveen Chandra, sir, from Medanta, Gurugram. And we have Dr. Sanjeev Roy from Fortis Escorts, Jaipur, Rajasthan. A very warm and hearty welcome to all of our expert panelists today here, sir. Right, and to kickstart our program, our first topic of the day would be by Dr. Jabir A. Dr. Jabir needs no introduction. Dr. Jabir is Senior Consultant Cardiologist in Lissi Hospital, Cochin, Kerala. He is a very senior interventional cardiologist with wide expertise in complex coronary intervention with a special interest in intravascular imaging. And without further ado, he's going to be talking today on predicting plaque progression and the role of RCT in the same. I hand over the mic to you for our inaugural session today. Dr. Jabir, sir. I think you're mute, sir.
Thank you, Salman. Am I audible?
Yes, sir. Perfect.
Yeah, you are very well audible.
All right. Thank you. And good evening. So I'll go straight away to my topic, the OCT predictors of plaque progression. This is a 59-year-old male who is a diabetic. He presented with an acute coronary syndrome in Jan 2021. As you can see, the right coronary artery, there was some mild lesion at the mid part of the right coronary artery. The circumflex was totally occluded. We did an angioplasty to the circumflex. LAD had some disease, which is less than 50%, perhaps around 40%. And this guy, he has been doing well till a month ago. In August 2021, he presented with accelerated angina and an episodic rest pain. You can see there is a tight lesion in RCA where there was no such lesion 8 months ago. And the left main, to our surprise, the left main, which was almost disease-free, now there is a 90% stenosis at the distal left main just prior to the bifurcation of the left main. And there is progression of disease in the LAD2. Another patient who is a 62 years old male, diabetic hypertensive, he underwent an executive checkup in 2014, where his treadmill was found to be positive, and he underwent a coronary angiography, absolutely asymptomatic, and his angiography revealed a long segment disease in the LAD to the tune of 70 to 80%. At one point in the mid LAD, it seems to be 80% with calcification. Others are all borderline lesions. He was advised a revascularization, but he opted medical therapy since he was completely asymptomatic. And he presented this month to us with accelerated angina. And you can see the progression of the disease in the LAD. The LAD is disease from top to bottom. The circumflex disease has increased. It is 90% now. The left main is okay, and the RCA is almost shutting. So if you look at these cases, there's a rapid progression of the plaque in this first patient, and there is a slow progression of the plaque over years in the second patient. So this data published long way back in 1999. This was a study based on 4 serial coronary arteriograms per year. They looked at the process of progression of coronary artery lesions from mild or moderate stenosis to moderate or severe stenosis. They could find 1/3 of the plaques at abrupt plaque progression, and in 2/3 it was a slow progression. Is it all plaques? Does it progress? This is a patient whom we did an angioplasty to the diagonal, which had a significant lesion, a major diagonal, in 2013 October. LAD had some 40 to 50% at that time. September 8, only 2 days ago, I did another angiogram to him when he came with some chest pain. And this time also the plaque remains the same, no progression. If you look at the area where we did the stent, it was a biovascular scaffold in the diagonal. That area seems to be okay. So there was no plaque progression at all. So when we look at the plaque progression, plaques may progress rapidly or slowly. Plaque may remain static for longer periods or may even regress. And it's a highly unpredictable thing. And coronary angiography is an extremely poor technology in predicting plaque progression. The plaque morphology, which is identified by the intracoronary imaging, could it be intravascular ultrasound, it could be OCT, or it could be NIRS, which it has a potential to predict the plaque rupture. And various OCT characteristics are associated with the plaque progression. The associated things are the thin cap fibroathyroma, a lipid-rich plaque, a lipid arc of more than 180 degrees, macrophages which are lined up, microvessels. This is a newly identified thing. The microvessels, this predicts plaque progression. The most important thing is the layered plaque, which is coming up with a large body of data to support that it predicts plaque progression and of course intraplaque hemorrhage. These are data which we know, the prospect study, the athyroma, IVUS prediction, athyroma, NIRS. All these studies have shown that plaque burden and a minimal lumen area of less than 4 millimeters square, they predicted May's rate, and it's predominantly, it was negative predictive value, not a positive predictive value. If you look at the morphological characters in the OCT, one of the most important thing is the layered plaque, which you can see here. You can see the calcium, the layered plaque, and a healed ruptured plaque. This healing and rupture, healing, further rupture, healing, this process of continuous rupture and healing is one thing that leads to plaque progression. And here also you can see the layered plaque with a lipid-rich plaque and also lining up of the macrophages. You can see the macrophages, the layered plaque, and the lipid-rich plaque with a white lipid arc. So what happens is a lipid-rich plaque or a TCFA, it ruptures and a subclinical thrombus formation, which organizes, leads to development of a new layer, it heals, and then again, another plaque rupturing over this layered plaque, further development of the layers, and this is the multi-layered plaque you can see here. This multi-layered plaque you can see down the images in the lower part, extreme right, you can see an image with with multiple layers and a organizing thrombus. With the white arrows, you can see an organizing thrombus. So baseline and follow-up, one layer. Second, the baseline and follow-up, multiple layers. And in the lower down also multiple layers. So this layered plaque is one of the most important predictor of plaque progression. Microvessels, you can see the microvessels here. These microvessels are an important, another important predictor of plaque progression, as well as this plaque rupture where an empty cavity, it is a ruptured plaque which is healing. And this is another one of our patients who presented with a thrombus, intracoronary thrombus, which is in the process of organization. It's actually a recanalized thrombus with multiple cavities. It's gradually organizing. So these are areas where the plaque ruptures, the thrombus forms, the thrombus heals, the thrombus gets organized and adhere to the vessel wall, the lumen. And here you can see another lipid-rich plaque with multiple areas of cholesterol crystals. So these are our plaques which are prone to develop plaque rupture. You can see the cholesterol crystals. The CLIMA study, which looked at the relationship between the coronary plaque morphology of the left antedescending artery and 12 months clinical outcome. OCT of LAD only in 1,003 patients, clinically indicated coronary angiogram from 11 independent centers during the period of 2013 to 2016. They looked at 4 criteria, the MLA of less than 3.5 millimeters square, and the fibrous cap thickness of less than 75 microns, a lipid arc circumferential extension of more than 180 degrees, plus an OCT defined macrophages. Close to 19% of the patients who experience a primary endpoint have a combination of all the 4 findings, and it was an independent predictor of the events. You can see all the various predictors, and the last one, a MLA of less than 3.5 plus a fibrous thickening of less than 75 micron with a lipid arc of more than 180 degree with macrophages, that has got a 6 times more chance of development of an event. And the other study which I have shown, this also showed there is a high negative predictive value and very, very low positive predictive value for these plaque characteristics. Positive predictive value is less than 10%. But at the same time, one study which compared IVUS versus OCT, that showed only IVUS a predictor of plaque progression. OCT-derived plaque characteristics were not independent predictors of atherosclerotic disease progression. But the last study which came in 2021, Jack, this month, the last month, August, a study which looked at the predictors of rapid plaque progression and optical coherence tomography study. 570 lesions in 248 patients, close to 10% lesions exhibited rapid progression. And the mean follow-up was of 7 months, and only 10% with rapid progression presented with ACs. This is the most important. 90%, almost 90%, it was asymptomatic. So that is what is happening. Asymptomatic plaque rupture, healing, and progression. So if you look at the predictors of rapid plaque progression here identified as a 0.4 millimeter reduction in the lumen size, a lipid-rich plaque, a TCFA, a layered plaque, macrophages, microvessels, cholesterol crystals, calcification, plaque rupture, and thrombus, of which statistically significant influence was of lipid-rich plaque, TCFA, layered plaque, and a borderline significance for macrophages. And when they looked at their multivariate analysis, only 3 factors had an influence or were significant with independent significance: a lipid-rich plaque, a TCFA, and a layered plaque. So layered plaque is coming in with a great importance regarding the plaque progression. So this editorial comment, what it says is a glimpse into the crystal ball. We know there are certain morphological characteristics which can be identified by intravascular imaging that may predict a plaque progression, but their positive predictive value is very poor. At the same time, they have a high negative predictive value. If it is not there, that plaque is less likely to progress. But with the current evidence, no matter how close we gaze into the crystal ball, our ability to identify plaques at higher risk of progression or complications remains limited. Thank you so much.
Thank you very much, sir. I think we can have a panel discussion on sir's fantastic topic and great insights into plaque progression via OCT. Professor Bahuleyan, sir.
I think it's a fantastic lecture by Jabir. And I would view it like that. The OCT actually is a great boon, because these things we were partly knowing from earlier studies, but the OCT has clearly brought into our ability to identify the plaque characteristics which you have mentioned as, thin cap fibroadenoma, lipid-rich arc, layered plaque, and macrophages, and all those things. And that is probably led us to find out what is the importance of finding out these and then predicting the progression of the disease. We are coming up into that predictions. But my question is that, now, how do you put this into our clinical scenario? How do you fit this information? Suppose we have available the OCT, and we know that the positive predictive value of this one is limited, whereas negative predictive value is impressive. So how do you put it into that when you have a multivessel disease, the culprit lesions you have treated, and in the non-culprit lesions, how you integrate? We have been trying to integrate it with the physiology like FFR, but how you integrate this in physiology, the imaging characteristics into decision making? Jabir.
This is mainly basically now for understanding of the plaque progression and the mechanism behind the plaque progression. What is the practical use of this thing? It is doubtful right at this moment, because we are not going to do OCT for evaluating all the lesions to know whether which plaque is going to progress. And all these studies were done in the non-culprit lesions. Culprit lesion, we know that it is the TCFA that is important, which may progress, which can produce an acute coronary event, and there, depending upon the judicious outlook of the clinician and with the help of imaging, we may decide on whether to stent or not. But if the patient is having, if an OCT tells us, shows us there are a lot of characteristics which can promote plaque progression, we have to treat them aggressively with the medical therapy. And there are certain data which shows that aggressive therapy, especially lowering cholesterol, was associated with a less event rate. So right now, the importance is it's most likely by chance if when we look at the OCT of a vessel, we see a lot of plaques which have characteristics to progress. There should be an aggressive therapy and we have to keep their cholesterol level extremely low. That is the practical point. That is one thing, that is the only practical utility right now. Otherwise, it is practically impossible to look at all vessels to know the plaques which can progress.
Yeah.
Exactly.
Any other, Kevin, you have any comments on to this?
Yeah, that was a beautiful review. Congrats on, I think, a comprehensive and very thoughtful discussion of what remains a contentious field. You know, the holy grail for this is to find with OCT, obviously, the plaques that are going to cause an MI in a patient 2, 4, 6, 8 years later. And so, you know, there are some research areas which hold promise. And in fact, my partner, Peter Stone here, who for years has worked on endothelial shear stress and the fluid dynamics across plaques in an additive way, which is not yet clinically practical in real time. If you start to layer other features of plaque morphology and hemodynamics, there may someday be promised that with an OCT signature of scary, dangerous plaques and an overlay of a shear stress profile, at least from some studies that were done around Prospect, we may get to a point where we can pick with 50% certainty a dangerous plaque that may cause an ACS in the future. And I think if we can fine tune those, all of this work, which has been going on for years, may have the ability for us in the trenches doing cases to inform us, hey, this proximal LED is dangerous. It needs to be treated today, even though it's 50% stenotic. That's a very contentious way to look at things, but I think the field has been pushing that way, and papers like the ones you've highlighted are the first step, because we need to understand the morphology that's dangerous, and if we can get it a little bit more fine-tuned, we can hopefully use some of this information to make decisions. And so, you know, congratulate people that are working in a very difficult field, and I think as technology gets better, there may be a day where we hit a button on our OCT machine, we get an endothelial shear stress overlay, and that may help us make decisions at some point.
Absolutely.
We're not there yet, though, unfortunately.
Dr. Sridhar, would you like to comment on the findings?
Yeah, sure. If you see the pathological progression of atheroma, at one end of the spectrum, it's intimal hyperplasia, intimal thickening. At the other end, it's a severely calcified veins. So in the beginning phase, they will have a lipid-rich plaques gradually replaced by fibrous plaques, then go into mixed plaques like a fibrocalcific lesions. At the end of the stage, they go into severely calcified vessels. So the one study, when it's a small study, but they have highlighted, this is indirectly, all the features are vulnerable plaques, like a more of spotty calcification, vasovasorum. That means more the vascular supply leading to more macrophage infiltration, leading to inflammatory features, and ultimately thinness of the thin cap fibroatheroma rupturing are leading to, again, thrombus formation, healing, again, if it is not, sometimes they may present with acute MI, sometimes subclinically, they heal, and again, it gets re-ruptured. So these are all common features. The one study looked at these features like Forza, which is a small study, but Forza, they compared the same what CLIMA study, like a pre-CLIMA, where like a lipid-rich plaques and the luminal area less than 3.5 square mm, and spotty calcium, vasovasorum, macrophage. They observed when these features are there, in such patient, they compared one arm FFR, another arm OCT. So when they compared, the OCT also scored very well. It also predicted the more events. That's the reason, recently when I went through the one Taiwan STEMI registry, that study has shown very clearly a non-infected, like when you are non-culpability there, whether to do it or not. At that time when you do the FFR is not available, you can also see the OCT mainly to see any lipid-rich plaques, the luminal area less than 3.5 mm, and more of vasovasorum, more of macrophage there. Based upon the Forza study, you can, but it requires a large data, randomized data, but a beautiful illustration, nicely nice observations, like even he showed very clearly the angiographic images correlating with the image, multi-layered, everything. Beautiful presentation. Thank you.
Fantastic, sir. I think we'll get on to our next topic, a very exciting topic here, OCT in stent failure by Dr. Kevin Croce.
Dr. Kevin Croce is Assistant Professor of Medicine at Harvard Medical School and Interventional Cardiologist at Brigham and Women's Hospital. He's the director of the CTO program, and he runs a research laboratory which does a lot of interesting translational research in devices which might come into clinical practice years later. Over to you, Dr. Kevin.
Thank you very much. I really appreciate the invite. I've virtually made a lot of friends in India now over OCT and imaging and complex PCI, which is something that I know we're all passionate about. Can everyone see my slides okay?
Yeah, very well.
Excellent. Great. So we're going to talk about OCT and stent failure for probably the next 16 to 18 minutes. This is something which in our practice we've learned to utilize in a very prescriptive way, because I think it has a large importance in terms of decision making for patients that are undergoing ISR. So data from the National Cath database in the US shows that in-stent restenosis is quite common. Reports vary that ISR currently in the US accounts for 12% of all US PCIs. And so given that we do about 1 million PCI procedures in the United States, this is a very common and important problem, which accounts for about 90,000 cases per year in the US. And a lot of the patients with in-stent restenosis, this is not a benign issue. They present with acute coronary syndromes and commensurately have worse outcomes. Data from several registries show that patients that have in-stent restenosis have a higher hazard of death compared to non-TVR patients. In a very nice paper by my friend Bobby Ye, who's at the hospital across the street from us, the Beth Israel, really showed quite clearly that ISR patients have much worse outcomes compared to de novo patients. So by way of summary, in-stent restenosis is common and it kills people. And so we need to think very importantly about how to protect these patients from bad events when they present with in-stent restenosis. So, we in the US do not have access to drug-coated balloons currently. They're in clinical trials. And, the mainstay of how to treat in-stent restenosis has been to put a second stent in. This OCT picture in the middle highlights the hazard of doing that because you get this onion skinning of layer upon layer of stent. And by the time you're putting a second and third and maybe fourth stent in, Einstein was quoted to say that the definition of insanity is doing the same thing over and over again and expecting a different result. And so because of that, we have been really busy in terms of our ability to treat ISR patients because we're one of the minority of centers in the US that has access to coronary brachytherapy. As you know, coronary brachytherapy is an older technology where we use radiation therapy to try to inhibit the smooth muscle cell proliferation that leads to ISR. And with the prevalence of multi-layer in-stent restenosis, 2 layers or more, we've seen dramatic growth, as you can see here, in the number of patients referred to us for coronary brachytherapy. And so with this growth in our practice of treating ISR patients, we've become very, very deliberate and diligent about trying to get them better outcomes. And I think imaging has an important role in promoting better outcomes for ISR patients. There's lots of reasons why stents fail: underexpansion, geographic miss, neoatherosclerosis, fracture, etc. And I really think it's impossible to do a good job treating ISR patients unless you use intravascular imaging, because depending upon whether there's fracture or it's undersized or underexpanded, or maybe there's neocalcific athero, it really changes what you do from a treatment strategy. And these are all facets of the ISR which the angiogram cannot detect, it cannot tell you. And so there really is an importance to intravascular imaging in treating ISR patients. So we looked at this in our Light Lab study, which I know many of you are familiar with. Ronnie has also done a very similar study in India, which I commend him for, which has been wonderful because a lot of the data coming from 2 continents agrees. What Light Lab did is it looked at the prescriptive use of MLD Max, which I know you're all familiar with, is our modern OCT image-guided workflow. We just simply asked the question of how does OCT change decision-making compared to maybe making decisions on an angiogram alone. And as you look at Light Lab, in employing MLD Max, which is just a very straightforward strategy, at 12 hospitals, 40 operators, we see that right away, physicians were employing imaging to a large number of complex lesions. And within Light Lab, actually 18% of our OCT guided PCIs were for in-stent restenosis. So this also proved there is a prevalence of this, which is important, especially in academic centers that get referred harder cases. But it allowed us to look at the impact of OCT in treating in-stent restenosis patients. And I think you're probably familiar because in some of the sessions I've participated in with Indian colleagues, we've presented this data already. But as you look across the various aspects of a PCI case, from pre-PCI planning to the post-PCI optimization, when you look at the ability of OCT to change decision-making, it changes decision-making across the cadence of a PCI case 87% of the time for de novo lesions. It actually has an even higher impact in in-stent restenosis, where it impacts decision-making 95% of the time. And so it really helps me to underscore and really highlight the importance of imaging in ISR. If anything, it's more important than in de novo lesions, at least through our Light Lab data. And I'll be interested to see if Ronnie's able to get similar data from iOptico. To my knowledge, I don't think it's been analyzed that way, but it'd be a neat way to look to see if there's congruence between what we found in our study and what colleagues there have been doing in India. So with that in mind, if you look at the impact of the OCT, it changes things that really matter, like assessing less vessel morphology, and then leading to addressing things like underexpansion, and most importantly, how we prep vessels, because we know that vessel prep is where the game is either won or lost in terms of addressing things like excellent expansion and plaque compliance. So with that in mind, when you apply MLD max and a prescriptive OCT strategy to in-stent restenosis, we're able to dramatically increase the minimal stent area. And ISR is a hard entity to get good expansion, but with imaging, we're able to make measurable and important increases in stent expansion in these lesions. So the other thing which is really important is that we started to focus on the treatment of patients with stent failure. We had been finding that underexpansion contributes very importantly as a main mechanism as to why stents do not stay open. This is data from the CRF group that looks at stent failure less than 1 year and greater than 1 year. Regardless of whether stents fail early or late, underexpansion makes up as much as 40% as the sole mechanism of stent failure. And so this starts to become an important conversation of getting it right up front, using imaging up front, using prescriptive strategies like MLD max to decide when to plaque modify, and making your first implant perfect so that patients don't come back with stent failure related to underexpansion. I would argue that this is a preventable problem with modern image-guided PCI. If you look at the patients referred to us for brachytherapy in a small cohort that we did careful core lab OCT analysis, if we define optimal expansion as at least 80%, if you're referred to my hospital for brachytherapy with 2 layers of failed stents, 73% of the patients fall under the 80% mark. So for us, multi-layer ISR has proven to be a predominant underexpansion problem. Not just 1 layer, but 2 layers. And if I have time, I'll show a couple cases of this. So with this in mind, we've been very diligent to try to come up with a strategy, an algorithm for dealing with underexpansion. Every stent failure gets obligate intravascular imaging. We will dilate like heck to be able to get an imaging catheter down there to tell us what's going on. And our treatment goal is to maximize stent expansion and lumen size, just like it is in every PCI. When we find the stent is underexpanded or undersized or both, we use high pressure ballooning if we're able to get it to expand well. Based on whether it's single or multi-layer, we'll either restent or use brachytherapy. And eventually we will have access to DCB like I know colleagues in India do have currently. In scenarios where the stents don't expand well, we use either laser with laser on contrast, or we now have access to shockwave IVL for about 5 months in the United States. And so this algorithm has shifted from just laser to now laser and or shockwave. So it's nice, new tools can make our lives easier. When these don't work, we then move into the arm where for expansion resistant in-stent restenosis with underexpansion, we use rotational or orbital atherectomy to drill out the stent struts. I should note that laser on contrast and orbital atherectomy for stent modification are very off-label, but there are many reports about its efficacy, and we have a lot of experience with that in our center. So the laser is able to change the compliance of calcium that surrounds a stent because this acoustomechanical energy, especially when you do it on contrast, causes a shockwave effect. This is an OCT-based stent failure study that shows on the right, if you don't use laser, In the middle, if you use laser on saline, or on the left, if you use laser on contrast, which magnifies this acoustomechanical energy, you see larger fractures of calcium around the stent struts. And these are the types of mechanisms that we're trying to harness to be able to get better expansion. In cases where we're unable to get laser or intravascular lithotripsy to work, we will do rotational or orbital atherectomy modification of the stents. The OCT here is helpful because it allows you to understand what you're doing. This is one of many of my cases where I have multi-layer ISR. It wouldn't release with a laser. I brought a roto down, and you can very clearly see that the roto ablates more than half of the multi-layer stents with a little bit of a divot in the intima. Because orbital goes in 360 degrees with its offset crown, the orbital modification of stents is very different. It tends to happen across the entire circumference. Multi-layer ISR almost completely ablated with the orbital atherectomy. And so the imaging helps us to guide our understanding of what we're doing in these cases and also assess our efficacy. There's an important role for intravascular lithotripsy in these cases that can make things easier now with our access to this technology. And so with our multi-layer ISR algorithm, we're able to convert patients that don't have the ability to get their stents expanded with balloons using a combination of laser on contrast, orbital, roto when necessary, and shockwave. We can go from unexpandable to much better expanded using this algorithmic approach, which is really highlighted by the need to image these stents. We've been finding that patients that have older DES have this very nasty entity of calcific neoathero, where the intima layer inside of the stents calcifies. This is a very difficult problem to treat, certainly. So in light of sort of trying to highlight the algorithm that we use and how OCT can impact our treatment of ISR, I have one case which came from our Light Lab study. It's a 73-year-old woman that had a prior DES to her RCA, came in with unstable angina and some ST depressions, and her prior history that she had a 3020 DES in her right. This is initial angiography with two areas of more diffuse ISR in the proximal RCA stent. You can see here that the angiogram-based decision was that it was 35 millimeters and the diameter was probably 3.5 and 4.0, and the vessel prep that was planned based on the angio was balloon only and then treat with a 3.5/38 stent. This is the cadence of how we looked at the angiogram in Light Lab, made decisions, and then did the OCT to assess whether or not the OCT would change our decision making. And what you'll be able to see on this OCT pullback is that the artery is much larger than appreciated with the angiogram, and there's calcific neoatherosclerosis within the stent that's probably moderate severity. And so with the OCT imaging, it really changed what we did. We would choose a larger stent. Distal is 4.0, proximal is 4.5. Cutting balloon and then up to laser and non-compliant balloons were felt to be necessary to get excellent expansion, and then we would treat with a 4.0/38 DES. The vessel prep was performed with a Wolverine. It did not release well. Laser atherectomy was done on contrast, pre-dilated with an NC balloon at ultra-high pressure, and a 4.0 stent, 0.5 millimeter larger, was placed compared to what would have been done on the angiography. So if you look at this, the final stent expansion is excellent. The reason I like OCT is with the automated measurements, you know right away whether or not you've achieved the adequate expansion in this case. And so the OCT led to a demonstrable change in what we were going to do in this particular example. 0.5 millimeter larger stent, same length, different vessel prep. And because we got it right up front, there was no major optimization required with a large increase in luminal gain for this patient. So the OCT is helpful in late ISR, but it's also incredibly helpful in immediate and short term. This is a patient who was referred to me, unfortunately, from a non-atherectomy small hospital, which is in our state, where they looked at the angiogram, they don't have ready access to imaging, and unfortunately, they under-recognized the severe calcium in the LED. This is the post-dilation of the LED stent that was placed, and the post-dilation balloon would not expand. And they were left with what they called a 30% residual in the LED. And so the patient was referred to us because the physicians were worried about the underexpansion in this acutely placed stent. And so as often we see the angiography does not show us the true extent of the problem. This is my setup angiogram, but when you did our Phillips stent boost, you can see that the stent is barely expanded, and the OCT shows quite clearly a rind of greater than 360 degrees with greater than 0.5 millimeter of calcium. And the stent is here. The minimal stent diameter is 1.1 millimeters. shown quite clearly to have a bow tie or dog bone. And so this unfortunately is a problem which will restenose and or can lead to stent thrombosis. So for us, we chose to use laser atherectomy on contrast, about 9 runs here, and with high pressure balloon inflation with an angiosculpt, we were eventually able to crack the calcium and get the stent to expand well. This probably does create some degradation in the polymer. There's a focal discussion about whether you might re-stent or not, but we decided to leave the patient with 1 layer. And if she has in-stent restenosis, hopefully by that time we'll have ready access to drug-coated balloons in the United States. This is sort of the classic patient that gets referred to us for coronary brachytherapy. 3 layers of stents in the right coronary artery with chest pain. And you can see quite clearly the OCT shows that there's 3 layers that are dramatically underexpanded. You can also see that fluoroscopically. This is the problem which should be addressed in the first stent, the second stent, the third stent. By the time a third one is placed, this becomes very difficult to treat. In this particular example, you can see a 306 angiosculpt at 30 atmospheres is completely unexpandable. And so in this particular example, again, using the acoustomechanical energy of the laser, we did laser on contrast extensively and eventually was able to get a balloon to dilate. For us, we do not want to place a 4th stent if ever possible. And so we went ahead and did coronary brachytherapy, treated this with radiation, and had an excellent final OCT result. I think the imaging here allows you to know the extent of underexpansion, whether you've got it expanded well, and what the correct sizing of the artery is in terms of choosing atherectomy devices and choosing balloons to dilate with. And so as we think about now, whether Shockwave has a role in this, we've had Shockwave in our center for about 3 or 4 months now. And so how it works with calcific neoathero, its role in multi-layer underexpanded ISR is something I've been learning. But as I've been learning that, I've been critically using OCT to understand whether it's doing something positive in these types of cases. This is a case I did just 48 hours ago, 72 multi-layer RCA stents. The number was possibly 2 or 3, came in with unstable angina. As I always do, I'm happy to balloon to then be able to do imaging. I took a 3.0 NC balloon at relatively high pressure and went ahead and did OCT. This is what the angiogram looked like after ballooning. It didn't look too bad, as is often the case. But you can see here that the OCT shows quite clearly 3 layers with calcific neoathero and a very poor minimal stent area. So I have more work to do here. I then went and took a 325 Wolverine, a 356 Sculpt, all at high pressure, and repeated my OCT. This is the co-registered OCT run, where again, the angiogram doesn't look that bad, but you can see the MSA has barely changed, and I still have calcific neoathero. I think in this type of case, orbital, laser on contrast, IVL are all in play. As a new IVL user, I wanted to see if this would do any impact. You can see the IVL was initially constrained, and as we had and did all of the pulses and then dilated with an angiosculpt, we were able to make a significant increase in the minimal stent area here. It's not perfect. I'd rather see this at 5.5, but when you're dealing with calcific neoathero and underexpanded stents, it's very difficult to get to 80% expansion. And that's something that we're looking at critically in Light Lab, just to see how we're doing with treating multi-layer ISR, knowing that it's hard to get complete expansion in these patients. So with that in mind, you can see we went from initially 2.4, high pressure balloons didn't move much, but the IVL did have a demonstrable impact in terms of the expansion in this case. So with that in mind, by way of summary, I'll go over the fact that ISR is an important and common problem. Underexpansion contributes importantly to stent failure. ISR patients have high rates of recurrence, so we joke about the fact that you really are the last stand for the patient if you're putting a second DES in to get it right. And an algorithmic application of imaging and when appropriate atherectomy can help facilitate expansion. And let me just put a plug in for Please Image All ISR, which I know colleagues on this call are inclined to do because you're all excellent. So thank you very much for the opportunity to present today. I've been really enjoying the interaction with colleagues from India who are doing some wonderful work there, and I look forward to being part of the conference this morning. Thank you.
Thank you so much, Dr. Kevin, for that fantastic talk with a lot of exciting data. And it's interesting to see how OCD changes the way we escalate the tools to tackle these failed stents. Now, I would like to hear from Dr. Balbir Singh. Balbir, sir, would you like to comment on the tools that we have right now in our country for lesion preparation or vessel preparation in such complex stent failure cases.
I think Dr. Balbir is not there. Dr. Sanjeev Roy, sir, could you give us some of your insights and views on this topic, sir?
I think Dr. Kevin has excellently reviewed the instant risk analysis, and I must congratulate him. And yes, we have currently a lot of armamentarium, like including beyond ROTA, we have the IVL and the recently acquired the laser. And I think in instant risk analysis, this laser modality is one of the one which works quite excellently. And as also the ROTA. We don't have an orbital atherectomy and we don't have an experience on that. But for the calcific instant restenosis, I think it's very important. The imaging plays the most important role. And in fact, any of the instant restenosis, as Dr. Kevin has been emphasizing, because you have to find out the reason of the device failure. You have to find out the lesion, what modification is to be done, and finally gain in the lumen, which is quite acceptable to avoid further restenosis. But I think the most challenging is the fact that when you have a multiple layer of stents, I think that's an area zone where we are into a dilemma, as even after plaque modification, should we stent that or just leave it within, just a drug-eluting balloon? I think I would like Dr. Kevin to address that.
Yeah, in published studies as recently as last year, drug-eluting stents have better efficacy for treating single-layer initial DES ISR compared to drug-coated balloons. And so, I think a second layer has better efficacy, but you need to make sure that if you're putting a second layer in, the expansion is going to be perfect, because then if it fails again, we're left with two layers, which, as I highlighted, is a very difficult problem. And so I think that's why, Dr. Roy, the imaging, as you noted, you have to be passionate about it, because if you're going to put a second stent in, it needs to be perfectly expanded, knowing that that is the last chance to deal with stenting for these patients, because the third stent is just going to start to pack the lumen and really start to crowd and prevent you from getting an MSA that's good. And so in the US, it's all we have. So single layer ISR for a DES gets another DES. But a lot of the DCB studies, if you look at them, they weren't 100% imaging. So maybe if we had DCBs with imaging and attention to expansion, the DCB data would look better than it does in prior studies. And so I think it allows us an opportunity from a research perspective to come up with an MLD max guided prescriptive stent failure algorithm of looking at DCB efficacy to see if by using modern tools and modern workflows, we can get these devices to behave better for patients by just getting the ISR to expand well. And so, whether DCBs fail because the technologies aren't as good or we didn't use them with appropriate vessel prep is something I'm often wondered. And I don't think we have an answer to that, but it's an important question moving forward. As we're learning to apply imaging to ISR, can we make these tools behave better with better outcomes?
Professor
Dr.
Bahuleyan, sir.
Kevin, we do not have a brachytherapy here. So if you have two layers of stents and you have an ISR, what would you recommend as an algorithmic approach?
Yeah, I think in that scenario, image, plaque modify to get hopefully 80% expansion if you can, and then DCB would be very reasonable. Brachytherapy is hard in the US because it's only available in about 25 centers. And so that's why we're so busy with this, because the technology is not widely available. We have to do these cases with a radiation oncologist because you need someone that's credentialed for radiation therapy, not just for diagnostic X-ray. So they're cumbersome cases to do. We typically have to do them electively, and it's not widely available. And so we look forward to the advent of DCBs because it'll give patients easier access to better technology for stent failure that's currently hard to get to unless you're near an academic center in the United States. So I think, DCB is effectively the answer. And lots of companies, including some ones that we're collaborating with, are working on newer formulations of DCB that have the potential to be more efficacious than the paclitaxel-based therapies, which have formed the basis of a lot of the data from Europe and I think from India that have really told us how DCBs work in instant restenosis.
Fantastic.
So we can get Limus drugs to stay in the vessel wall. We may have more efficacious DCBs in the near future.
Fantastic there, Kevin. Bahuleyan sir would like to wrap up this.
I think it is a great talk, Kevin. I think you have summarized very nicely the importance of using intravascular imaging. especially I would say optical coherence tomography in all cases of instant restenosis to guide on your treatment, knowing fully well what's the mechanism of instant renosis in a given patient. I just wanted to have a quick question to you. The calcific neoatherosclerosis is being increasingly recognized when we started using imaging. Do you have a special algorithm of managing this calcium compared to the de novo lesion calcium? You have shown several cases. I just wanted to have a quick summary on that.
Yeah, it's a great question. And so classically, I had used orbital because it goes in 360 degrees, and at least mechanistically, it should core out the neocalcific athero in-stent in a more deliberate way than roto, which is wire bias directional. So the reason I showed you the shockwave case from 2 days ago is because I'm wondering, will that change the compliance in a way where we can get better expansion? And so in my practice, it used to be an orbital problem, but I'm in an open-ended way wondering how IVL might be useful there. And maybe colleagues on the call have more experience than we do because it's a new technology here, but it's a place where we need better tech, because dealing with that problem and getting good MSAs with calcific neoathero is very hard. I showed you the case. We did better, but not perfect. And I strive for perfect in these cases. So clinically, we're realizing it's more of an issue because we can see it because we're doing more OCT. It's been there for a long time. I think we just didn't realize the scope of the problem until we started to apply imaging tools in a deliberate way.
Thank you very much.
Great session indeed. Fantastic there. I take this opportunity to thank all our expert panelists here on this session 1. And we will be moving on to session 2, the live case. We have our live case ready from NIMS Hospital in Trivandrum. I'd like to take this opportunity to invite our expert panelists for this session. First on my list, I have Professor C.G. Sajeev, HOD, Department of Cardiology in Calicut Medical College in Kerala. We have with us also Dr. V.S. Prakash from MS Ramaya Hospital, Bangalore. We have, continuing with us, we have Dr. Jabir from Lissi Hospital in Cochin. And we also would like to invite to continue Dr. Kevin Croce from Harvard Medical School to continue as our expert panelist for this live case coming up soon. So would you like to introduce our live case, Dr. Shafeeq?
Yeah, thank you, Dr. Salman. We have a live case transmission from NIMS Hospital, Trivandrum. I think we are live now. Dr. Madhu, can you hear us?
Yes, Dr. Jabir, can you hear me?
Yes, very well, very well. Good evening, Madhu.
Hi, good evening, Jabir. Good evening, Dr. Sajeev, Dr. Prakash, Dr. Croce. So we'll start.
Dr. Madhu.
Now before.
Dr. Shafeeq and Salman here. Good evening.
Yeah. Hi, Shafeeq. Thanks for the invitation. Thanks to be part of this great program.
Welcome. Okay. So can you please update how much you're up to and about the case that we are doing today?
Sure, great. So before we start, we'll introduce my team. I've got Dr. Kiran with me, Ashwati, Mahesh, Sujit, Sharat. Aishwarya is a cath lab technician, and we got Sharat to help with the OCT. All right, so we'll have the presentation of the case. Right, next. So this is a 61-year-old gentleman who presented with new onset of angina class 3 for 2 months. He's 69 kilograms, 170 centimeters. Next. He had an ACS 20 years ago while in the Middle East. He stopped smoking after that. His risk factors include dyslipidemia and hypertension. Next. His lab investigations, his hemoglobin is 15, creatinine is normal with a normal creatinine clearance. He's not a diabetic, SpO2 was normal, and the LDL was 106. He's on diltiazem as antihypertensive, along with rosuvastatin and antiplatelets. Next. So the ECG is essentially normal, and the echo showed no RWMA with good LV function. So he had an angiogram elsewhere, and this is the angiogram report, and he had triple vessel disease, and he was advised CABG. But somehow the patient was not keen on a bypass, and so he came for possible angioplasty. So the left main is normal, LAD will go to the angiogram. So next. the angiographic syntax score was 21. The syntax 2020, the 10-year mortality with CABG would be 14.5, and with PCI is 18.6. So, equipoise with some benefit with CABG. Next, so we'll just have a look at the angiograms. So in summary, it's a 61-year-old, ACS 20 years ago, no details, with new onset of angina, class 3, hypertensive dyslipidemia, ex-smoker, syntax score of 21. Next. There's an angiogram. You can see the LAD, there's a tight lesion in LAD. The OM1 is not a very big vessel, but it's disease from the ostium tapering to occlusion. Next. You can see the LAD D1 disease. It's a bifurcation, Medina 111. Next. You can again see the OM1 filling in distally. It's a disease from the ostium with long segment. Next. And an RCA had a mid 80% stenosis. So he came with his angiogram. So we thought, for complete revascularization, you need to do something for the OM and the RCA, and of course the LAD-D1. First option was CABG, but he was definitely not keen. So we thought we would open the OM1 chronic total occlusion, now which probably was 20 years ago, but we're not certain, but it's deceased from the ostium. Next. So he came, we tried the OM1 a few days ago, and with a fine cross and first a failure XTR wire, which is not making any way. You could see there's a bridging collaterals, there's a capus mudicis kind of thing before the distal OM was filling up. So after the failure XTR, we took Gaia first next, but unfortunately it went into the intrapericardium. Now, at this stage, we stopped there and again discussed with the relatives. I mean, if they wanted a CABG, because the OM1 probably we would not be able to do it at this stage. We may have to do it later, if at all. And they, the patient and the relatives, they didn't want surgery, whatever. So at that stage, there was no pericardial effusion. The echo was normal, and the patient was hemodynamically stable. So we just completed the RCA. I mean, that could be controversial, but because the patient was stable and there was no fusion. Next, we did a stent for the next one. RCA. It is a next. This is a 3x38 signs, and we stopped. It's 3 days before. And he has come now for angioplasty for the LAD-D1. Next. Today's case. Can you show the angios first, please? First one. So we started with a right diagnostic, which showed a good result with the angioplasty before. And this is a shots which you have taken today. Next. The LAD diagonal. Next. So the LAD was wired with a whisper and the diagonal with a run-through hypercut wire, and this is pre-dilated with a tube balloon to ensure that we get good pictures in the OCT. And we did an OCT from LAD and diagonal. So we'll have a look at the OCT now, and after that we can have a discussion regarding the plan. First one is can you have the OCT, please? Yes, this is the OCT from LAD, which show that the distal LAD is fairly okay. Yeah, it's predominantly fibrofatty plaque. At the lesion, you got dissection following the balloon angioplasty, and proximal LAD was large with no significant disease. Size-wise, distally, we got a dimension of 3.1 and 3.2, that is a EEL. And proximally, we couldn't get an EEL because it was deceased and there was lipid cross. But the lumen was 3.2 into 3.0. And left main is huge. So we also did a OCT from diagonal, which showed that the diagonal distally was clean. It was just at the ostium. Ostium, it is fatty fibrous plaque with tight disease in the ostium, but restricted to the ostium. And the rest of the diagonal was clean. So this is where we are now. We're just waiting for the plan and the comments from the expert panel. We got a LED diagonal. We got a distal size of 3 millimeter. The length was 23. And diagonal disease was restricted to the ostium, and distally was free. So if at all we are planning for a stent, it would be a 3x23 stent. And our approach was essentially a provisional because it's a relatively simple kind of bifurcation with the lesion restricted to the diagonal ostium. But yes, it's open to discussion.
Thank you, Dr. Madhu. Excellent case. I think we have a Medina 111 bifurcation with a good sized side branch with a very short segment side branch ostial disease. That's right?
Yes.
Okay. So, Dr. Prakash, would you like to comment on your strategies, please?
Yeah, excellent case. And yeah, I definitely do agree with Dr. Madhu because the diagonal ostium is diseased, but the rest of the vessel is clean. So if you look by the definition criteria, you don't have a long segment side branch involvement. I would go for a provisional stenting and then probably just open the side branch, do a pot proximally, and then watch and see if at all there's a need for a provisional stent. You can plan for one later on. But otherwise, yes, single stent strategy would be the right way to go in this case.
Sajeev sir, would you like to comment?
Yeah, same single stent strategy. Because diagonal is only short ostial lesion, single stent if possible.
Dr. Madhu, what was the diameter of the diagonal? I didn't catch that. The diameter
The
of the
diagonal was 2.5, 2.5 EEL. But at the proximal, the ostium of the diagonal, there's a bit of an ectatic segment. At that area, it was around 3. But the body of the diagonal was 2.5 EEL.
And what would be the angle?
Be acute angle. It will be less than 70.
Dr. Kevin, would you like to place your comments, please?
Yeah, it's a beautiful case, and I think a nice, thoughtful presentation of a patient with multivessel disease, a CIRC CTO, and much like you, I would try the CTO first, such that if unsuccessful, it can heighten the conversation for whether bypass surgery is reasonable, and you did that, and the family and patient opted against it. So I think treat the LED diagonal, and if he needs to, he can come back for a dedicated attempt at that. I think that CTO is probably openable, but it may not need to be, because if you can convert him to being asymptomatic with the other angioplasties, I think that's fine. I do try to get complete revasc in young people, but that's not always possible. And I think, if he's not completely asymptomatic after, the CIRC could still be in play. The one thing I wanted to ask is that the OCT of the diagonal shows a little bit of dissection after ballooning it. So I would just, the only thing I would worry about is if it's a narrow angle, which I recall it may be, that recrossing could be difficult after you have carina shift. And so, yeah, that's helpful there. It's not too heavily dissected, which is good. The other thing which I'm always careful to do is integrate.
Dr. Croce, I was just wondering if the dissection, I thought is predominantly in the LAD or the ostium.
Yeah, you're right. It looks okay.
Yeah, a bit of a
not
dissection,
bad at all.
Yeah.
That's helpful. That's another thing to integrate with regard to the decision making here. So the fact that it looks not heavily dissected, I think further supports a one stent strategy. And in a scenario like this, I'll usually pin the wire behind the stent strut after placing it across the diagonal, just in case it closes. I then have a marker to shoot for, but I know there is some variation in practice with that.
All right, so shall we go ahead with the stent then?
Yes,
If everyone has agreed on a single stent strategy.
Madhu, one thing, it seems to be a pretty big diagonal supplying a large area, clinically relevant diagonal. Very tight ostial stenosis, VMET and a very narrow carinal angle. The OCT findings are all suggest that there is a high likelihood of closure of this vessel with a significant disease at the ostium. Though we may think of a single stent, I think we should be really prepared to go ahead with the 2 stents. Most likely the diagonal is highly likely that it may close down and we may have to go ahead and stent the diagonal, though we may think of a single stent. I strongly feel that we may finally require 2 stents.
So Dr. Jabir, would you have gone 2 stent strategy upfront or?
I would have gone two-stent strategy upfront.
If yes, what would be your preferred strategy?
I thought the diagonal size is a little lesser than the LAD size. I would have gone for a DK crush. It's a quite narrow angle. It's not a small angle. And the disease of the diagonal ostium is close to 80%. And we have dilated it with maybe perhaps a little bit of the dissection also there. So I'm a little different from the opinion of the other panel members. I may be considering a two-stent strategy.
Well taken. I think we'll proceed with the case. Dr. Madhu, how did we go ahead?
So what is the consensus about the expert? Because we are essentially waiting here because to generate some kind of discussion regarding this. So would be a single stent or a double stent?
The consensus is that we have two viewpoints. So both of them, which are well taken, I guess. If you got to score it, I guess we go for a 3-1 score.
Yes, as for the EBC, I thought, we'd just see. I mean, we might end up in two stents, but as we say, it's provisional as a strategy. It's not one stent alone. We can always go for a second stent if at all we need. Yes, exactly. It's going to be a tap. It's going to be an acute angle. It's going to be difficult. But in case we can get away with a single stent, probably it would be better long term. But you just have we'll go with a single stent provisional strategy.
And Dr. Madhu, I just want to know one more thing. If it is tightly pinched after the stenting of the main vessel, will you do a FFR or will you go with your visual assessment? Or you look at the ECG, whether ST changes or the patient develops pain or something like that?
We'll cross the bridge when you come to it, Jabir. But essentially, we would be just crossing. We'll be doing a kissing. We'll be doing all that first.
Okay, as Dr.
Balloon embedded technique.
Sorry?
Yeah, Dr. Sajiv is suggesting a balloon embedded technique for protecting the side branch. What is your comment, Dr. Madhu?
Yeah, that is something which is popular, but yeah, I thought it'll be more conventional.
Okay, as Dr. Madhu proceeds, Dr. Kevin, I would like to know your practice pattern in non-LMCA bifurcations in your cath lab. Do you routinely image all those non-LMCA bifurcations like this?
Yeah, I think an LED diagonal bifurcation of this magnitude of the large side branch, we will usually do image both limbs. And as you beautifully outlined, take a very, just direct MLD max strategy. So, you define the length quite nicely. You pick the EEL based stent sizing distal and made a decision based on the disease in the diagonal, whether you would need to do two stent or one stent. And now you've got the case plan such that if you have to bail out a stent into the diagonal, you know exactly what length and size to place. And so it's a really nice example of prescriptive imaging as a way to guide bifurcation stenting. And it's really important here because bifurcation stents are high risk for failure. So it's a place where imaging is going to have a great impact potentially in sizing appropriately in a patient subset who we know are at risk for stent failure. So it's a great illustration. And I typically, by way of summary, will image both limbs whenever possible.
Dr. Kevin, would you like to depend upon the imaging to know whether we have to recross into the side branch by looking at whether it's only the cells across or this the connector across? And if it's a connector across, we'll definitely cross and do a kissing at least, or you leave it if the vessel flows well.
Yeah, so I think you suggested that cross-sectional area is not a great way to make decisions on any revascularization, and so if the diagonal is in question, I tend to put a resting physiology wire down it to check. Some people would advocate for maybe just jailing a physiology wire there behind the stent, and you can then hook it up and check. That used to be worried about because the sensors were bigger and there's a risk of entrapment. At least in practical practice, that is shown to be safe by other colleagues and many people now. So there's a couple different ways to do this. My good friend Jag Singh from WashU he's a big proponent of a jailed balloon in this scenario. I have to say, I haven't done a lot of that. Usually we can just recross and get through again, but there is some talk internationally about, the merit of that. And I'm excited to hear that people on your continent also talk about it. I've not done it a lot, but, and the other thing is, regarding the decision of whether to treat, if it pinches substantially, I think there's a true value to RFR, IFR in that situation. And we typically don't, colleagues in Asia are very deliberate about intercurrent OCT to determine which strut you have crossed with. I don't know that there's enough data other than benchtop show, and you may get a little better looking carina, but we don't typically take the time to do assessment of where we cross by OCT, but we are careful to go down with the wire and bring it back and try to cross in the most distal strut. That's sort of a way to get, possibly more distal, but you can check it by OCT, which I think some people would advocate for. I'd be interested to hear what the team there does with regard to that.
I think Dr. Madhu has stented the main vessel, and it looks like a pot, Dr. Madhu.
Yes, we put a 3.5, 3 into 23 stain as per the OCT, and the diagonal is pretty okay. So now we're going to do a pot. We are taking a 12. 12 is a bit too long, so we're taking a shorter balloon for the pot.
The side branch looks okay as of now, right?
Side branch is not too bad.
I think this is a good point for discussing like what Dr. Jabir raised as to how to assess the physiology of the side branch, what would be the strategies, FFR, eyeballing, ECG, OCT. Those are the things as to the significance of the side branch. Professor Bahuleyan sir, would you like to comment? We were talking about the side branch and how to assess the significance of post-stenting of the main vessel.
Thank you.
Good evening, Bahuleyan
I think
sir.
in this particular case, one of the other informations which you could have gained from OCT is what should be the length of the port balloon. That's another thing which you can made out, and appropriately you can use the port balloon just at the carina and then perform the port. That's another information obtained from the OCT. Well, regarding the side branch, by my practice, I go by this non-LM bifurcations, diagonals, if it is reasonably good size, if the flow is quite okay, and if the stenosis is not very tight, and the patient is asymptomatic and no STT changes, I accept that. Then, well, I also look at a post-PCI imaging by OCT, and that single run from the LAD to distal to the proximal, you can actually identify the size of the side branch ostium. Because angiographically it may be looking severe, but when you do an OCT, you will find that it is not that much compromised. And if the flow is okay, no changes and no chest pain, I will leave it rather than doing a FFR. And again, if you have a dissection suspicion at the ostium of the diagonal, using the pressure wire is not that easy. Sometimes it can exaggerate the dissection of the ostium. So I would rather hesitate to do a FFR. In this case, the flow is quite good. There is some pinch all right, but the patient is okay. No STT changes. I think I will leave it at that. And he has not performed the pot. After performing the pot, probably it will look better.
Yes, Bahuleyan sir, there was a bit of an issue with the ACR because for the live case, there's only one pot and that had to be taken. So otherwise, we had taken the size as 13 millimeter, but because the ACR wasn't there, the stent was placed a little bit down, which is why there's this problem with the length.
Yeah.
Dr. Prakash, would you use FFR interrogation of the side branch after stenting often? What is your practice?
I would go more by the clinical scenario and the angiographic visibility of the side branch. And in case it's a large vessel, say we're doing a left main bifurcation, yes, probably circ or the LAD looks clinically significant angiographically, I would probably do a FFR. But I think with a diagonal, which is just about 2.5 millimeter, and the area of supply is not large, patient is stable, I would hesitate, especially with a ostial dissection of the diagonal. I'd be very careful before introducing a FFR wire. FFR wire is a little too, it's not as, the profile is a little more, so the problem could be that you could worsen the dissection and create more problems and lose the side branch. So be very hesitant to use an FFR here.
Totally agree. Dr. Kevin?
Yes. So, a scenario like this, it has to do a little with patient age. I mean, if the patient, we always joke in our lab that a diagonal never killed anybody, but they can be a source for angina. So if you leave it severely pinched and the patient's under conscious sedation and they're not having chest pain, EKG looks okay, it's rare, but we have had in our center some people that, you know, go to cardiac rehab after and start having chest pain from the diagonal we pinched. And so in a young patient, I think you said 61, if there is any question, it's severely pinched, I might assess it with IFR, RFR, but in this scenario, it's looking pretty good so far, and I don't think there's an extreme need to do that currently.
Right, so we have done the pot with a, you know, that's a 4x8 balloon, and the result, the diagonal is okay. There's a bit of a pinching of the diagonal. So we are trying to cross into the diagonal through the distal part of the strut, distal struts, and then probably do a kissing balloon. Now, the wire cross, there are two ways. One, you can keep the first wire there to see, look at a marker to see whether there's separation of the wire and the first one, to see whether it's a proximal versus distal cross. And of course, we can also do an OCT to ensure that it's a distal cross.
Dr. Madhu, why did you use the 4 millimeter size? What made you use that? What was the criteria?
So the OCT was 3.5 lumen. We could not see EEL based on that, and it appeared a large vessel. So it is 3.5 on the lumen. So that's why, and we didn't go to very high pressures. So.
Yeah. Okay.
Which wire did you use to cross the side branch?
This is a cyan black. Can't really see separation between the two, so. This looks more promising. We probably would do an OCT here to see whether it's distal strut or not.
Yeah.
So there's a jail wire being taken off.
Dr. Kevin mentioned that he's not too particular on which strut he crosses, distal, proximal. Yes. There are only bench studies,
Yes.
is what you mentioned, Dr. Croce, right?
So would you normally do a OCT to see for the distal cross?
You know, we have done it. I can't say that I've gotten to the place where we do it as a matter of routine practice. You know, I think that from at least bench studies and OCT studies, you know, crossing will matter for the confirmation of the bifurcation and coverage of struts to lessen the chance of side branch ISR. So, you know, it's not a bad idea. The fact that it demonstrably affects outcomes, I think, is a little bit lacking, but at least conceptually, it's reasonable. And if you have the time and good kidneys, you know, I would commend you for doing it, because it is an extra attention to detail, which I think this technology allows us to be careful with.
Indeed, yes.
Does the panel routinely do intercurrent OCT to figure out strut crossing, or are you a little bit more laissez-faire?
Sorry, Dr. Croce, didn't get that.
Oh yeah, I was wondering, colleagues on the panel, do they routinely check with OCT, you know, after recrossing to see, or is it something where you take a little bit more of a measured approach?
Bahuleyan sir, what would your be?
No, I generally don't do that. I use the angiographic guidance to get the distal crossing, by getting the wire down into the LED and coming back from the distal to the proximal and then getting into the distal strut. That's the one I usually use.
Yeah, and I think Dr. Bahuleyan, you know, although that is imperfect, that at least increases your chances of being distal as opposed to wiring it integrated and potentially getting in more proximal. So it's a little bit of a nod to expediency and being quick, but if you have the time and want to be conscientious, there's certainly no fault to using the OCT. It's the way to get it certainly right, and the bifurcation view can be helpful for knowing where you are.
Dr. Elvin Kethi, welcome. How are you doing?
You put my voice on. Yeah.
Yeah.
I'm good. I'm sorry. I have to excuse myself. I was driving home and I'm completely get stuck in the traffic. So I'm doing this from a restaurant that I found that I could do this. So
Okay.
I'm absolutely sorry. Something has happened.
You're
in
looking
Brussels.
too perfect
It's
for
all
a.
stuck.
Yeah. Thank you. How was your session in Seoul? It went well?
Yes, it went well. And that was this morning. And actually, it was
Time
a
zones.
discussion
Time
exactly
zones.
like this from Dr. Akasaka.
Okay.
And he is, this is, I guess, a bifurcation. Should you do assessment of where your wire crosses the struts, right?
Yes.
Yeah.
This was an LED diagonal bifurcation. Medina 111 and our operator Dr. Madhu just stented the main branch, did a pot, recrossed the diagonal, and we're doing a post-stenting OCT right now, and that's what's coming up on screen.
Yeah. Now, the Dr. Akasaka, which is very acquainted into this, he is a fan of doing it on the Japanese way, taking all the steps and getting it right. And so it could be done in a routine daily practice. Sometimes if I'd be a left main, I will do it. If not, if it's just LED diagonal, it's not that's going to change much. Most of the time, diagonals are not more than 2 millimeters. So left main could be nice to do it.
So I think we have our OCT on, our post-stenting OCT.
Yes, OCT. Can show the bifurcation view. Yep. Come, 2.5 and 3.5 fast.
I think this is a good time for those
Yes,
juniors
it
watching
is,
to see what all the
it
max
is probably
Go on, Madhu.
yeah. But it is probably at the distal part. You got a connector there, but distally there's not too much. But I think so.
It looks.
There's not too much there. Anyway, we have at least tried. So we'll just do a kissing just to make sure that it's optimal.
Yeah, I think, Madhu, it looks like, it looks suitable for that, the jailing pattern of the side branch. If you place a balloon and then send it, you can, that it can, deflect back the jailing pattern, the stent strut to the periphery of the ostium of the diagonal.
Yeah, it's a little hard to tell without going frame by frame, but I think based on where the most distal strut is, there's only a very small space. So where you are is about as good as it's going to get without spending an inordinate amount of time. You may end up back in that spot anyway. So I would give this a green light go. I think it looks fine.
Right. So we got the wire into the diagonal, probably a distal cross. So it's a 2.5 balloon. Yeah, it's crossed pretty easily.
Because you have DCBs in India and we do not in the US, would you use a DCB at some point in this case, gentlemen?
Yes, we do have DCB. Yeah, go. 912. DCB probably it's a good indication for a DCB here.
Well, I mean, we don't have them in the US. So, I've followed the literature from Europe and people's practices with great interest, but I have no experience. So that's why it's nice to collaborate on these types of sessions because the team here has, better probably algorithm and application for that than we do in the US.
Dr. Jabir, what would your practice of DCBs in side branches like this, non-LMCA versus LMCA?
We mostly these type of cases where it's the branch is 2.5 millimeter in size, we'll go ahead. If it is a de novo lesion, we'll go ahead with a stent rather than a DEB. Our DEB use is almost limited to small vessels, the diffusely diseased vessels where we can't put in stent, or restenotic cases where the side branch develops severe restenosis with 2 layers of struts across. So he may not. Our use of DEB is quite limited, mostly in restenosis and very small vessels, and not for these type of lesions where the vessel is 2.5. We may think of a stent rather than using a DEB.
Dr. Elvin,
Nine.
do you have DCBs in your country?
This is a dot, so to say, distal optimization with a 3.5 into 12. And now we're going for the kissing balloon with a 3.5 in LAD and 2.5 in diagonal. Nine.
Sorry, I didn't get very well the question. You were asking if we use DCBs, so drug-coated balloons in this setting, or?
Yeah. Do you have that in Belgium?
Yeah, we have that in Belgium. Not in a, I don't know if this is a restenosis case, but normally for just a straight-on bifurcation, we will not use that if we're using stents. So. We will use it on a side branch eventually, but mostly it's not done. We will go for a provisional and not put a DCB on the side branch.
There was a question here from the chat box, Dr. Madhu, did the post-stenting OCT show any edge dissections proximally or distally? I think there wasn't any, if I remember.
Sorry?
There was a question from the chat box showing whether there was any dissections proximally or distally post-stenting OCT.
No.
I would think no, right?
No.
Yeah, so I think that's a good setting to, like Dr. Kevin mentioned, the MLD max algorithm going for those juniors attending, probably following the MLD max algorithm. Pre and post PCI would be a religious thing to follow. What do you say, Dr. Shafeeq? Looking at your medial position, expansion parameters, and medial dissection. Bahuleyan sir, I think that step-by-step approach, pre and post PCI should be the norm for all beginners in imaging.
Yeah, I think so. That is, I think we have now some evidences, growing evidences that this algorithm works very well in the cath lab, and then the procedure becomes use of actually OCT, and the whole procedure becomes faster. Just to do a pre-procedure after, if you require a pre-dilatation, do that, measure, study the morphology, measure the distal reference, proximal reference, and in between the length will be available. Decides on the balloon, port balloon, this is being done. And then, place the stent and then optimize it. I usually do the optimization, means generally if you find some under expansion angiographically itself, do a high pressure and then make the post procedure run. And many a time it may be okay, but even when angiographically it looks okay, after the second run, you may have to do optimization by using, under expanded area, you have to use a higher size balloon or a higher pressure. And then you achieve the expansion, proximal as well as distal, at least 80% of the reference, if not 90%. 90% will be desirable and 80% will be acceptable. And there should not be any significant dissection either proximally or distally, and significant malposition, if recognized, it has to be corrected. Then you get a perfect result. Angio-coregistration is another advantageous thing in the OCT, which could be used, and that gives you clear placement of the stent from the distal marker to the proximal marker with ACR gives you. This should be the algorithm. Only one question, Madhu, again, you have done that, the kissing balloon inflation, the size of the balloon for the side branch and the main branch, and the pattern of kissing balloon, would you sell for the juniors who are attending this program?
So we got the size of the diagonal as 2.5. Okay. So we had used a 2.5 balloon. So we first went into the diagonal and opened the stent struts to make sure that the stent is okay. We didn't go at high pressures because it is a provisional approach. That's what you're planning to keep. So it just to open the struts and ensure that the lesion and the diagonal is opened up. And the kissing balloon was in the LAD. We used a 3.5. again at 9 atmospheres, because we found that the size of the LAD proximally was almost 4, so we used a 3.5 distally. So the EEL and the very distal was 3.1, 3.2, so we didn't go to very high pressures. But again, as it was provisional, we just went to normal pressures. So here, the LAD stent looks good, but you have a dissection in the diagonal ostium. Now the question is, do you want to stent it, or do you want to not stent it? So it's again the expert panel.
To stent or not to stent, that is the question. Dr. Kevin.
Yeah, I have to say I'm a little bit schizophrenic about this because, we have clear data that medial dissections, at least at the edges of stents, in particular the distal edge, is somewhat hazardous from a MACE standpoint. But then, in the CTO space, we do limited dissections and star bailouts and leave arteries completely dissected and then bring people back 8 weeks later and they're wide open, and then we can complete their stenting. And so as much as, in a simple stenting case like this, I'm inclined to deal with dissections with stents because they tend to behave better. I've got lots of experience that heavily dissected arteries tend to stay open. But I think in this example, it's a large vessel. We all agreed upon the fact that it is an important one to protect. And I'm trying to look at the angle. It looks like you could probably pull off a tap bailout without having too much carina hanging in the LED. So I would be inclined to either reverse mini crush it or deal with a second stent of it. But there certainly is no right answer. The odds are it will probably stay open. If you wanted to get more information, you could put an OCT down there and see how bad the medial dissection is with regard to the worry that you'll pressurize it and it might close down acutely in the next couple of days. But I'd be inclined to probably deal with it just straight up with a mechanical stenting approach now.
Dr. Madhu, what is your plan now?
Now we are doing an OCT now into the LAD, and depending on what you find, we can put a stent. It can put a small stent in the diagonal with a tap. So what Jabir was asking for, let us come through. But I thought it is always good to give at least a provisional a try, because it's always better if you have just one stent.
Yeah.
Now we could do a mini crush or a tap, or whichever. And we'll just do a OCT from LAD to see how it is.
I think the important point, though, is the degree of pinching was not bad, and if it had maintained that lumen but had not dissected, the provisional strategy would have been certainly reasonable. And so I'm trying to anticipate whether it's going to dissect is a hard thing to do.
Choosing the next strategy would be interesting. Dr. Jabir, what kind of two-stent strategy at this point, the second stent strategy?
I'll go for the simplest strategy. I'll go for a tap. The ankle not favoring a tap, but I'll go for a tap rather than going for a much complex.
Keep it simple, you mean?
Keep it simple.
Right.
Madhu, could you give us another shot to see the diagonal ostium?
Yeah. Gotcha. Good.
We'll be running out of time shortly. I think after we go through Dr. Madhu's OCT, we'll probably
we'll just
try
do the
to,
OCT and then
and we'll probably get back to you on how we proceeded with the case. We'll have a look at how this thing turned out. As Dr. Kevin suggested, getting a run through into the diagonal would also have been good to see how much of the dissection is involved at the ostium.
In fact, Salman, that would be a perfect thing to do, to see if OCT shows that the ostium is okay without much plaque and the lumen is very good. We can leave the diagonal without going.
Yeah, and especially if there's not a lot of intimal hematoma, if it's, a medial hematoma. If it's just a little bit of subintimal dissection, which sometimes you can see on the angio, and the OCT can exonerate that the medial involvement and there is no hematoma, that might be a case where the OCT would allow you to defer on a second stent here. And so it's certainly a reasonable way to go.
Yes, we'll do our OCT into the diagonal as well. And if it's yeah, just one more minute. And
Yeah,
if that is not too bad, I'm inclined to leave it at set. But if, on the other hand, it's a large dissection, we probably would put a stent.
Yeah, perfect plan.
Your OCT shows one thing very clear. As Bahuleyan sir suggested earlier, that kissing has moved the stent struts away from the ostium. Now the ostium is clear.
Ostium is clean.
So, it's totally clear of the struts. That connector has been taken away and it has become a part of the, I think, a part of the proximal part of the main vessel stent.
Yeah, from the LED.
So Jabir, I think that is a possibility that he can do a diagonal OCT pullback also without much problem with the ostium.
Yes, sir, absolutely, sir. Absolutely.
That generates another question: is kissing balloon dilatation mandatory in all non-LMCA bifurcation, irrespective of the diagonal size? Dr. Kevin?
There is a dissection which we are seeing that is
yes.
Is that the diagonal ostium?
It's a diagonal ostium, yes.
Right, it's a significant dissection.
Yeah.
Yeah, there is a big medial flap.
Yes, yeah.
I would have a hard time deferring on this one. It's greater than a quarter.
Yeah, we'll put a stent. We'll put a stent into the diagonal.
Yeah, there's luminal involvement.
Okay, Dr. Madhu, I think our transmission is over, and our next talk is due. Thank you so much, and definitely we would see the final result when you join for the last session today.
Yes.
It was wonderful to
great demonstrations.
Absolutely.
Very nice.
Thanks, Shafeeq.
Very nice case.
Well done. Thank you, everyone.
Dr. Rose, yep. We'll see again in the last part of the meeting when we'll show you the pictures, the final pictures.
Thank you very much. Thank you to all the panelists. I think we'll, great case there. We'll move on to the next session, OCT in bifurcation. So how we would plan OCT in bifurcation stenting. I would like to take this opportunity to invite our expert panelist here for this session. We have Dr. V. Sujata, Senior Consultant Cardiologist from Indus Hospital in Visakhapatnam. We have Dr. Kaparthi from Care Hospital, Banjara Hills, Hyderabad. We have with us Dr. Rajpal Singh from Fortis Hospital, Bangalore. We also have with us Dr. Umeshan CV, Senior Cardiologist from Aster MIMS, Kannur from Kerala. And last but not least, we have Dr. Shiva Prasad, Professor of Cardiology from Medical College, Alipi. All right, so the next session, we already have a warm welcome to all our expert panelists there. For our next session, our speaker, Dr. Elvin Kedi, who had already joined, were kind enough to join us before. A short intro there. He's a senior interventional cardiologist from Sint-Jan Hospital in Belgium with a vast experience in OCT and IVUS-guided PCI, an expert in structural interventions, including TAVI and MitraClip, and also an innovator with patents and inventions of several catheters, including the Amigo catheter, escargot catheter, and the spiral catheter. A warm welcome to you, Dr. Elvin Kedi, and handing over the mic to you for the next session, combined why FFR alone is not enough. Over to you, Dr. Kedi.
Thank you. Do you hear me?
Yes, yes, indeed.
Yes, good. Thank you. I think that some of you have seen some of these slides, and I will do this presentation in a bit different today, and I'll show you why a combined FFR and OCT means in clinical practice. So the idea of this based on the combined trial, and the idea of the combined trial was based actually from a sub-analysis I had a chance to do from the data of the prospect trial. And what we found there is that in diabetes patients, it triggered me that the majority of the events during the follow-up from these non-culprit lesions were very light. There were 20-30% actually on angiography, most of them. Arrived from the non-culprit lesions other than the culprit lesions, and within these culprit lesions, particularly what we could define on IVUS as ThinkUp fibroadenoma was the major trigger in these patients. These were diabetic patients, but this was also the case in non-diabetic patients. The problem is that in the prospect, the FFR was not performed and the IVUS resolution is insufficient to detect TICFA. Therefore, I designed Combine, and that was what we did in the Combine. The hypothesis is that the medically treated diabetes mellitus patients with angiography intermediate but otherwise non-ischemic FFR negative coronary lesions will have significantly different clinical outcomes depending on presence or absence of the plaque vulnerability features, the OCT detected TICFA in this case, with TICFA carrying patients having the worst prognosis. Of course, we performed this study in the diabetic patients as they represent the patient subpopulation with the fastest atherosclerosis progression. So what we basically did, we took patients that we were thinking this is an FFR, we should do FFR in this lesion. So they were 40 to 80% diameter stenosis, and we call them the target lesions. We performed the FFR. If the FFR was positive, we did the full revascularization. If there was at least one lesion with an FFR that was negative, then we divided them on group A or group B, depending on presence or absence of TICFA. And the primary endpoint looked to the difference between group A and group B, where secondary explorative secondary endpoint looked to the group with TICFA with the group that had full revascularization. The study endpoint was a combined endpoint of cardiac death, target vessel myocardial infarction, clinically driven target lesion revascularization, or hospitalization due to unstable or progressive angina at 18 months. So we basically did the study, and we had about 300 patients that were FFR negative and had no TICFA, about 100 patients that had FFR negative, but they had a TICFA. And there were about small 100 patients that had no FFR negative lesions. They had stents in all their arteries. As you could see, there were clearly FFR negative lesions with an FFR in both groups, group A and group B in this case, so TICFA positive and TICFA negative of 0.88. And there were further no baseline differences between the groups apart from the fact that the TICFA was somehow found in lesions that were longer. When we looked at the morphology data on the qualitative OCT data, we could see that as previously described in these in the anatomopathologic studies, there was a larger lipid arc and there was more neurovascularization and macrophage infiltration in the TICFA patients. And as you have seen already, there was a much higher event rate in these target lesions. So originating from these target lesions that were FFR negative, it was 30.3 versus 3.1. And most importantly, all the myocardial infarctions and target lesion revascularizations occurred there. And these were actually the drivers, although we have unstable angina, all the unstable anginas led to revascularization. So this did not actually impact the primary endpoint. So these were clinically driven revascularizations. Importantly is that the TICFA was found a predictor, so almost about 5 times higher, 4.5 to 5 times higher event rate. And other important thing that we found here was the minimum lumen area. So combined showed that there is a prevalence of these lesions of about 25%. That is a strong predictor of MACE. And importantly, for the first time, it divided this concept of ischemia and future adverse events. And we think that these are two separate things, that the future adverse events are mostly related to the plaque morphology. And that's why the combined FFR and OCT is important. Now, I want to take this data that I showed till now, you've seen, but I want to show you this other concept of how we have to think from here now on. And you see that there is a progression of plaque, as you all have seen. There is a plaque cholesterol accumulation. There is the first platelet fibrinogen, and leads to sometimes an acute coronary syndrome, either that is acute or overt. Occult or overt, and then sometimes either we have to deal with acute coronary syndrome immediately, or this plaque will heal and create a stenosis. And these are sometimes where and this brings also the concept that actually stable or unstable angina are actually deriving from same type of plaques. And that's where we do the FFR. And as you know, when we do an FFR, 1/3 of it will be positive and 2/3 of it will be negative. And these negative FFR negative lesions we put on medical treatment, and we know that it leads to plaque stabilization. However, there is permanence of these plaques in about 20 to 40% despite high statin treatment. So what is the relevance of these plaques? We don't know it, and we have to study this. But I would say, if we look to the FAME2 if we see that actually what we see is there is a progression from there is a progression, but this is driven only mainly due to the need for revascularization, and this is about 20%. So remember this number, about 20% need for acute revascularization. We have 20% of patients again in ischemia trial needing revascularization. So basically what ischemia is telling you is that there is actually a group of patients, about 20% that absolutely need it, and maybe these are not exactly what we're looking at now or what we're treating right now. And therefore, what are these 20 patients? Those are patients that had already a severe FFR, less than 75 maybe, or even less than 70 at baseline, or also lesions that were FFR negative, but that they have progressive progression of plaques. And what is important for me, also in the FAME2 5-year results, there was a difference also in myocardial infarctions, and this occurred in the late phase. As you could see, about 70% though, also in the FFR group, FFR guided group treatment, also had myocardial infarction. The same was seen, the 70% was seen also in the ischemia trial, if we look to the spontaneous myocardial infarction. So I can understand that there are infarctions in the conservative arm, but where does this infarctions, spontaneous infarctions, come in the non-conservative arm? And we're not talking about the periprocedural infarction. So I think this is not by case. And if we look again to these maths of the FFR in intermediate lesions, we'll have 1/3 of them being positive and 2/3 of them being negative. So this is exactly the 70% of these plaques that are again being left untreated, which might be the trigger for new events, exactly what we've seen here. And in other words, infarctions can also derive from non-ischemic lesions. And this was also very nicely shown. This division of 1/3 and 2/3 was shown from the collaboration group between these Korean and Japanese groups. As you could see here, there were 1/3 of FFR negative and 2/3 of FFR positive. But I want to point you that the absolute number of these plaques, of these vulnerable plaques seen in this CT study, was actually also 2/3 in the FFR negative group and only 1/3 in the FFR positive group. On a percentage, they were higher in the FFR positive group, but on absolute, still 2/3 of them were left untreated. And also you could see also where the events also came from. The majority events come from these patients, and you could see here exactly this blue line shows these FFR negative lesions and the events seen from them during the follow-up. So these are not innocent. And again, also in this slide here. So there were more events actually when these were left untreated than the FFR group that received PCI. So the majority of the events, exactly as we saw initially from the prospect, derived from these lesions that were left untreated because they were FFR negative, but despite being high risk. So we also showed this clearly prospectively now on a combined trial. And we are not the only, because if you could see also Dr. Takashi Kubo doing the OCT study, he showed something very important. He showed that the infarctions are deriving mainly, the new acute coronary syndromes are deriving mainly sometimes from lipid plaque. If you have TICFA, is almost double, but if you have TICFA and lipid-rich plaque, you have 3 times more infarction, acute coronary syndromes than just having lipid plaque alone. And this is what I want to share also with you. This is new data that we're showing you from the combined. We looked to the patients and we divided only the patients that had lipidic, non-lipidic, and lipidic and TICFA. Of course, we had patients with plaque burden more than 40, with a stenosis more than 40%, which automatically leads to a plaque burden that is more than 75, if you do the math. So what we found is that exactly as previously shown, the lipid plaques, of course, have more events than the non-lipid plaques. Let's say when we're saying non-lipid, these are fibrotic plaques. But if we split the lipid plaques, on the right panel, you'll see that this, we just got this data. This is the TICFA group here. And you could see that the TICFA, the events are driven mainly from the lipidic plaque and TICFA, where when the lipidic plaque and non-TICFA has almost similar outcomes at the long follow-up as the, these are long follow-up data, as the non-TICFA, as the fibrotic plaque. Therefore, it is true that lipidic plaques have a higher risk than non-lipidic plaques, but this higher risk is mainly driven by lipid-rich and TICFA lesions, exactly as Dr. Kubo showed, while lipid-rich TICFA lesions have a very good prognosis. So therefore, I'm saying that these persisting inflammation and vulnerable plaques, I believe these are the ones who will give, again, acute coronary syndromes. And therefore, that's why physiology alone is not enough and imaging should be considered. So take-home message from here is that FFR-guided revascularization significantly improves symptoms, the angina, however, not significantly enough, it does not reduce ACS or MI or mortality. That now we know that the lipid-rich plaque and TICFA lesions are at higher risk for future events independently from ischemia. Should we treat these lesions? No evidence yet, but we are proud to announce that there is a combined tool that will start soon as a global trial, and for interested centers, they can contact me. Thank you.
Well, that's an interesting talk, Dr. Elvin. Thank you so much. This is especially relevant in our country where there are a large number of diabetic patients. Now, I would like to take the opinion of our panelists. Bahuleyan, sir, what would you like to comment?
I think I have listened to this Kedin several times on his combined work has been published and presented at least different forms. I'm very much impressed about this concept which he's working about, because several years ago we were also thinking that plaque characteristics and plaque morphology have come into the picture in decision making of treating intermediate or non-coagulations. It should not be left alone to the functional assessment, given some of the fallacies of FFR in acute coronary syndrome and to a certain extent in other lesions also. Now I think we are figuring it out fairly nicely that thin cap fibrotheroma has got maximum importance in predicting probably the event rates in non-coagulations as well as FFR negative cases. And now add on with the lipid rich plaque and thin cap fibrotheroma probably will give us an idea that in intermediate lesions, even if the FFR is negative, this can be added on, and probably instead of leaving on to medical treatment, we can probably fix it with by stenting. We will require more data for this concept to be put it into practice. My question to Kevin is that you have found that FFR negative cases developing events, and that is basically because of thin cap fibrotheroma. Now, what was the FFR range of those patients who developed events? Was it borderline like FFR of 0.82 or 0.83 like that? Do you have a split up of that? Number two, is the event rates, is it happened is it towards the early part, or is it spread out all throughout your follow-up? Please.
Yes, that's a very good question. We looked to that, and it doesn't look like FFR is a predictor. You could have a plaque that an FFR that was I don't know, around over 90 that could give you a problem as an FFR of 82, and so we did a plot, and it doesn't look like it. There is a line there that shows that it could lead to, that there is a correlation. We don't see a correlation. However, this is the FFR, but the minimum lumen area does impact. So minimum lumen area actually is more important than the FFR itself, because it's actually less the minimum lumen area, more the plaque burden you have. So it's related to each other.
Regarding the events, was it spread out throughout the follow-up, or was it in the early part?
No. It was continuously, and it started to take over after. Actually, I'll say you saw the curves. The curves are going on continuously. So there is not a moment that you say there is nothing to do with stopping of doing antiplatelet therapy or something like that. These patients actually were maintained on it. So we do not find anything on that direction.
Thank you.
It's a continuous ongoing.
Great. We'll take some comments from our expert panelist. Dr. Kaparti, do you have some?
Dr. Elvin, thank you very much for the nice thought-provoking this one with combined two trial. Our view of management may change because of the large number of diabetic population in our country. And here, this is the one of the important subset where morphology scores over the physiology. Most important. We have not only this, in some cases actually, especially when associated microvascular disease in hypertrophic cardiomyopathy with coronary disease, we face the similar problem. So where we have used the patient has a almost hazy lesion, and we did the OCT. OCT is showing almost the thin cap fibroathyroma, and of course the FFR it is negative actually. IFR and FFR both are negative, because we know that in hypertrophic cardiomyopathy there is associated microvascular disease, where we ultimately stented, taking this along with where morphology scores or the physiology. So any inputs of this type of cases where associated microvascular disease, OCT role compared to the IFR or FFR?
I think there is another interesting thing to notice here is, imagine this plaque. This plaque, what we found is very interesting, is that it's not that there is just this plaque and you have a thin cap atheroma. There is a longer lesion. You see that this lesion has been active from a long time. It has ruptured once, healed. There is a plaque rupture next to it, but the old plaque rupture is a healed plaque. It's a calcified lesion. And then again, you find the lipidic part of this, the same lesion, where they have a thin cap fibroadenoma. So my understanding is that the progression of atherosclerosis in these patients become longitudinal. So it's not a clear cut to say this is a fibrotic. So we talk about predominantly, but unless the progression of atherosclerosis is ongoing. So what you can think also, that every time these plaques rupture and heal, because we clearly see a repetition of this phenomenon, of course there is some microemboli, some microthrombi that goes to the distality. So this could, in the long term of this lesion being progressive, particularly in diabetes, cause some microvascularization, higher resistance in the microcirculation. And this could lead to an FFR negative when you'd expect visually to be an FFR positive. So this kind of disbalances, plus the existence of this plaque and the turbulency that it gives to the flow, could lead to sometimes FFR being negative, while with all chances it should have been positive. It's surprisingly negative sometimes.
Exactly. Dr. Shiv Prasad, do you have any comments to make on this, and how do you think whether practice could be changed by this paradigm shifting trial by Dr. Kedi?
There is an excellent exposition of the fact that these lesions which we think as FFR negative are becoming significant cause for acute coronary syndrome later on. But I don't think this has been enough evidence to change or make a paradigm shift in our practice at this point of time. We need more data, as Kevin suggested. We need to have a combined two trial results. We should have as early as possible to see whether this sort of an approach is going to alter the prognosis in these patients, especially with a huge burden of diabetics in our population. We see that many lesions during acute coronary syndrome are looking like vulnerable, but we go and do the culprit lesions in most situations. And time and again, we are called back to refer to the other lesions which we have picked up during angiogram, during the acute coronary syndrome itself, to do the procedure. Do you have any comments that while doing a procedure, is there any role for ACS, for the other non-culprit lesions? OCT?
Yes. I first of all, you said different concept during your statement. So I first of all want to thank you, because I also want to make the point that the data is still, it's just only one trial. The second is retrospective data that I showed you already from the data from Dr. Kubo, and then we have the data from the CT from Dr. Lee. But again, we also have the data from Dr. Prati. I'm also very cautious. I don't say to people, go ahead and stand this now. Please note that I started this. This is a project of 10 years. We started with retrospective data. We looked at in the FFR patients from our clinic, they were still having problems. We published this. I looked to the prospect. We found the same thing. We did a prospective but natural history study to see if this is true, and we found this in the combined. So now it's time to, there are other data, as I said, coming, pointing to the same direction. So now we are doing a randomized trial. I cannot disclose the design of the randomized trial yet, but it will be something with a combined FFR and OCT and different strategies of treatment. And of course, is there a role for OCT? I think there is, because also in the session that we had this morning, there was a session in Seoul. There is more and more coming the data. OCT is becoming a tool that is becoming unmissable in the cath lab. And I believe, particularly in India, I am surprised how diffuse the lesions are in India. It gives you a lot of information in doing a good job. And also maybe sometimes also money saving, because you can start doing a segment with a stent, but then you see that you need another and another. And if you do it from the beginning, you might also be more cheaper in the end than
exactly.
Therefore, so you could do a good job.
Fantastic. Dr. Sujata, would you like to share some insights, please?
Sir, most of our practice is now is acute coronary syndromes, and we know that the non-culprit lesions are not doing well by FFR. Like the recent data has shown that there's no difference between angiography and FFR driven between the two strategies. So do you think we should do an OCT driven strategy and then have some sort of score, like a score which includes certain characteristics, and then help us do certain lesions, especially the non-culprit lesions?
Well, right now, not yet. As I said, you need data for that, but that's where the data is pointing out. At the moment, you should base this on your own judgment, but I could not, based on what we have till now, say you go ahead and treat it this way. So I believe this is, for the moment, it opens us a door to do some more new research and maybe find a new way, but we need a trial for that.
Dr. Umeshan?
Yeah, very excellent presentation. I have a different thought. FFR and OCT are two different tools. FFR assesses the physiology and OCT assesses the morphology. You all know that it is morphology which determines the future events. So I was wondering, why should we need FFR at all then? Why all these patients should go for an OCT and identify the vulnerable lesions and go for it? Because there is a lot of cost involved in combining these two. This is just for a discussion I am saying. So in our country, cost is a major issue. Do an FFR, then divide them into two. One is negative, then do an OCT, then determine. So how much we can use this? This is a very great knowledge, very great, no doubt about it. Coming into
good news
practice and taking into the cost consideration, how much it is going to help us.
There is good news. There is a catheter with both coming soon.
Very good, excellent.
So till now, do FFR. If you really have doubts, do OCT, and this catheter is coming. It will be soon there.
We have Dr. Deepak also. Deepak, welcome. Your final comments, please.
Shafeeq, I was listening to Dr. Kedi. It was a wonderful session. I've been listening to this particular topic even prior to this. It's a very new area, new arena wherein we need to give a lot of importance, at least in patients who present with acute coronary syndrome. Thank you. It was a very informative talk, Dr. Kedi.
I think we'll go on to our next talk by Dr. Deepak himself. The talk is on OCT in non-LMCA bifurcation. Just to introduce Dr. Deepak Davidson, is the Chief Interventional Cardiologist from Caritas Hospital, Kottayam. He's a very senior, renowned expert in complex interventions with no need for introduction in this part of India. I'd like to hand over the mic to Dr. Deepak. Over to you, sir.
Good evening to all of you. I hope I'm audible and you're seeing my screen too.
Yes.
Yeah, very well, Deepak.
Yeah, thank you so much. First of all, let me take this opportunity to thank SA Heart Foundation, Dr. Shafeeq Salman team, Bahuleyan sir. I'm also happy to share the screen with Dr. Elvin, Umesh and Kapardi, Sujata ma'am, as well as Shiva Prasad sir. Over the next 10-12 minutes, I shall take you through the usefulness of OCT in managing bifurcation coronary lesion, non-left main bifurcation lesions. Start with the case history of a 55-year-old lady who had polycythemia on treatment for that. She gives history of acute coronary syndrome a year ago. Now she again presented with troponin positive acute coronary syndrome, and she was on dual antiplatelet therapy, statins and beta blockers. Now she was taken up for angiographic evaluation. You could see that the right coronary artery was very clean, no lesions at all. The left coronary artery, the left main looks good, the circumflex looks good. And you could also see that there is hazy looking stenosis right from the proximal left anterior descending artery across the diagonal branch and well beyond the diagonal branch. You could also see that there is some hazy looking stenosis in the diagonal branch also, as seen in the epicranial view. Well, this is the caudal view wherein you could see that hazy looking lesion, it's almost in the proximal left anterior descending artery, reaching almost till the almost reaching till the ostium of the left anterior descending artery. Those are the frozen frames wherein you could identify that the lesions very clearly over there. So we had two thoughts in our mind probably. One is she's been having polycythemia, 55-year-old lady, clean coronaries like circumflex and right coronary artery. Probably it was an in situ thrombosis a year ago, and she's got a recanalized vessel. That recanalized thrombus looks like that, and probably again she had an clot formation over there. So probably that was an acute coronary syndrome related to that. And second thought, probably it was a spontaneous coronary artery dissection, which happened a year ago, and that's again she again presented with an acute coronary syndrome. So these were the lesions that we made out. It's an LAD-D1 bifurcation. The lesion into the diagonal branch is extending long way down into the diagonal branch. So we decided on image-guided revascularization of the LAD-D1 bifurcation. As expected, we had challenges in crossing the lesion. The wire wouldn't straight away go into the LAD. It was a Versatone wire. The first one, it went into the diagonal branch. We wanted to get the wire into the diagonal into the LAD first, but it was not easy for us to negotiate that. So the Versatone wire that went into the diagonal branch, and the second wire was a Fielder FC wire. We could negotiate it in the left anterior descending artery. We took a 2.5 millimeter balloon and did a gentle dilatation of the entire left anterior descending artery before we went ahead with a first OCT run. Now, how does first OCT run help in evaluation of the bifurcation? Well, as we all know, we presently now look at the MLD max. Pre-procedure, we always have an evaluation of MLD. That's the morphology, the length and the diameter of the lesion. And when it comes to bifurcation, we also have a look at the bifurcation angle as well as the branching point, carina tip length, like what we had a discussion during Dr. Madhu's live case. So that's the morphology. So we had an evaluation of the left anterior descending artery. If you look at the morphology in the L mode, you could see that there is honeycombing of the proximal left anterior descending artery as well as the mid left anterior descending artery. That's the cross-sectional image. You could see in the cross-sectional image, that's a honeycombing or the lotus root appearance. You could see that this is more like a recanalized thrombus sitting over there. And you could also see in majority of the areas, the vessel looks reasonably good, except in this frozen frame, you could see that from 6 o'clock to 12 o'clock position, you could see that there is intimal thickening. It looks more like a pathological intimal thickening. So initially we had a thought that there is a possibility of a spontaneous coronary artery dissection, but looking at all these things, we understood that it was a thrombus that had formed over there. Probably she had a plaque erosion long back, had a thrombus there, the vessel got occluded, now recanalized. So that's what we are seeing at this point of time. So that was a morphology. Moreover, we also made out that it was more of a bright looking areas. It was there is no significant amount of lipids over there. So we were happy that when we do balloon dilatation, we are unlikely to end up having a distal slow flow. So that's what we made out in the morphology. Again, that's the 3D reconstruction of the morphology. You could see here that there are multiple planes, multiple areas wherein the wire was initially going into, and we were finding it difficult to wire the LED. Well, we also assess the length of the lesion to be stented. Here you could see the ostium of the left anterior descending artery. So we decided that probably the lesion was extending almost till the ostium. So we decided that we should cover the lesion right from the ostium of the LED way down beyond the diagonal branch. And the lesion was almost 43 millimeters in length. We also had an evaluation of the diameter of the vessel. The distal LED was 2.5 millimeter. The proximal left anterior descending artery was almost 3.5 millimeters. So we thought that we'll make a small compromise. We'll go with a 2.75 millimeter stent, under deploy it, and then do a proper post dilatation. So that's what we decided based on the length. So a 48 millimeter expedition and 2.75 expedition, which is deployed at 8 to 10 atmospheres, and further aggressive post dilatation. What was the strategy like? Now we would also have a look at the bifurcation. We would look at two important points, like the angle, that's the carinal angle. Once the carinal angle is very narrow, less than 50 degrees, you're likely to close down the side branch when you do a crossover stenting. And secondly, you could also look at the branching point carinal tip length. If it's less than 1.7 millimeter, again, there's a chance that you could close down the carina, you could close down the side branch once you do a crossover stenting in the left anterior descending artery. So that was a carinal angle. You could see here over there, the carinal angle is narrow. It's almost 50 degrees or so. However, even though the carinal angle is narrow, you could see here that there is some amount of thrombus sitting at the mouth of the diagonal branch. So, so there is a small chance that if we decide on a provisional strategy, these things could close down the side branch during the stenting of the main vessel. We also looked at the branching point to carinal tip length. That's the branching point till the carina tip length. This length is almost 2.5 millimeters. So again, it's more than 1.7 millimeters, making us feel that we are unlikely to close down the side branch based on these OCT parameters. But what made us feel that we should commit to do strategy was this particular thrombotic things, and the difficulty that we had in wiring the LED and diagonal branch, because we felt that if we decide on a provisional strategy, in case we wanted to go cross into the diagonal branch, it might be at times challenging for us. So we decided that we'll go ahead with a two-stent strategy in this particular situation. So we did lesion preparation, stent at the diagonal branch. It was a pretty long lesion. That was a 2.5 38 expedition stent. It's being positioned with a couple of struts into the left anterior descending artery. The stent was deployed at 12 atmospheres, and subsequently we pulled back the stent balloon a couple of millimeters and further deployed at 16 atmospheres and removed the balloon as well as the wire. Now we could see that the flow in the diagonal LED is good after the deployment of the stent in the diagonal branch. Then we removed the wire from the diagonal branch and did a crushing with a 2.75 millimeter balloon that was positioned in the left anterior descending artery. Once we did that, we tried to recross into the diagonal branch. Now it's also recommended that one should try to do a non-distal crossing into the side branch. So once we crossed with the Versatin wire into the side branch, we also did a OCT run. You could see in the OCT run that the wire which is coming from the left anterior descending artery, it's gone through almost the middle strut into the side branch, middle cell into the side branch. It's a non-distal crossing. The idea would be to prevent the wire from going beyond the stent between the vessel wall. So that was what was done. We recrossed into the side branch, which was evaluated with the OCT run. We also had a discussion during Madhu's case presentation that probably one need not always look into all these very, very minute parameters. So once we did that, how does OCT help during the procedure? How does it help to evaluate? It would also help us to evaluate the effects of plaque modification. When you have a calcified lesion, you could also see whether you have fractures. During the stenting, you could also assess the wire position following recrossing, whether you want to have a distal recrossing when you do a provisional strategy. When you do a decay crush strategy, you would always want to avoid the most distal recrossing. So all these parameters could be made out, and you could also see the stent cell parameters and the links and connectors and possible poor outcomes following kissing balloon inflation. Well, that's how most of the stents would look like. You would see those those crowns as well as connectors like this. When you have a connector sitting just at the carina, then following kissing balloon dilatation, like what you see in the first image, when you have a connector sitting at the bifurcation, following a kissing balloon dilatation, you might have a little bit of stent malapposition. But when you have a non-linked carina, then following kissing balloon dilatation, you have a perfect stent position. That's what the data says. Now, coming back to our patient, you could see here in the first top frame that the wire has gone into the side branch through the non-distal cell, and which was again evaluated with the bifurcation mode. You could see in the bifurcation mode that the wire has gone through the proximal cell, through the middle cell, and not through the distal cell into the side branch. Now, what is interesting is you're not seeing the stent, rendered stent over there. You could see that only a very little amount of stent has been crushed over there. So that's the reason why you may not be, while doing a DK crush, you may not be able to see a rendered stent over there, because you have very little amount of metal inside the main vessel. So that's the reason why you may not be able to see the stent rendering of the crushed stent over there. But you could see in this particular example that when you crush the stent, when the crushed stent is too much into the main vessel, you can always render it and see, as you see in this example, wherein you have an LAD-D1 bifurcation lesion. We did the lesion preparation, stenting was done. You could see that the stent is protruding way back into the main left anterior descending artery, almost it's 5 to 8 millimeters back into the left, into the LAD. And once we did the crushing of that particular stent, the stent was deployed because we miscalculated the length of the stent, and when the stent was deployed and crushed, you could see that once we recrossed into the side branch, now you could see that the rendering of the crushed stent is very clearly seen, primarily because too much of stent was extending into the main vessel. So normally when you have a couple of struts protruding into when you do a very short amount of protrusion into the main vessel, you may not be able to see the rendered stent, but in this particular situation, you're able to see that. That's a final result in this particular situation, wherein we again went ahead with the further steps of DK crush. Now, coming back to our patient, we made out that the wire has gone into the side branch through the non-distal cell. So we went ahead with a kissing balloon dilatation. Prior to kissing balloon dilatation, we also had a high pressure inflation of the side branch with a non-compliant balloon, and subsequently we stented the left anterior descending artery with a 2.75 48 millimeter expedition. And before we recrossed into the side branch, we did the proximal optimization as seen over here. Once we did the proximal optimization, again we had to recross into the side branch. This time again tried going through the middle cell. We got the wire into the LED, pulled it back, and tried to recross into the side branch. And once we did that, we again did an OCT run just to see the position of the wire. You could see here that the wire is actually going through the non-distal cell. It's almost the middle cell into the side branch. And again, that was confirmed in the bifurcation mode over here. You could see in the bifurcation mode that the wire has gone through this particular cell into the side branch. You could see that there is link over here, which makes us feel that once you do a kissing balloon dilatation, there might be some amount of malapposition over here. So you could see that link at the carina. Of course, it's not under our control. So you could see that the link is over there and the wire has gone into the side branch through the non-distal cell. Further, we dilated it, kissing balloon dilatation, proximal optimization was done, and that was the final result. You could see that the flow in the LED was good. Angiographically, the result was looking perfect. But then post-stenting, you would always want to evaluate further. That you would always want to look for medial dissection. You would always want to look for apposition as well as expansion, as well as the bifurcation. So that's the bifurcation. That's the final OCT run in this particular situation. Distally, you could see that there is absolutely no dissection over there. You could also see, when you look at the opposition indicators, you could see that there are two areas of red dots over there. Primarily, that's because of the septal artery, septal branch coming over there. That's why you would see the non-opposition indicator being red over there. And at this particular area, that's the diagonal branch coming over there. So that's the reason why you would see the red indicators over there. You could also make out that the stent is expanded well, a good expansion. And that's the final bifurcation seen over there. You could see that there is some amount of cells which is a bit malopposed over here, primarily because that link was present over there at the bifurcation. Following kissing balloon dilatation, the diagonal ostium looks perfect. However, you could see that there is some amount of strut sitting over there. So that's the bifurcation, final bifurcation you could see in the L mode. And this is the final bifurcation of the LAD-D1. You could see that the LAD-D1 as well as the ostial positioning of the stent. You could see that the stent is positioned well right at the ostium. The circumflex ostium is very clearly seen, as well as the diagonal ostium is also very clearly seen. So that's how one would go through while doing an evaluation, while while evaluation as well as post-procedure optimization of a bifurcation. I'll share a couple of two cases in 2 minutes time and then stop my presentation. This is an LED D1 bifurcation. This particular patient had a stent in the left anterior descending artery. Few years later, he came with an ACS. You could see that the diagonal has got a very critical stenosis. We decided on a TAP technique over there. So the TAP was done. That's the angiographic evaluation. Post procedure, you could see that this is the LED D1 bifurcation. You could see that there is one strut, that is T, and protrusion. One strut is actually protruding into the left anterior descending artery, which can be made out in the bifurcation mode. This is how probably one would want to position the stent inside the diagonal branch. Probably one strut needs to be protruding into the main vessel. Again, that's a fly through showing us that clearly one strut is protruding into the main vessel, and that's just a short case on Culotte technique. Why does DK crush? Why DK crush does better at bifurcation compared to Culotte technique? That's the explanation for that. When you do a DK crush technique, you have a wide looking confluence following the procedure, but when you have a Culotte technique, you wouldn't usually have a wide looking confluence. You tend to have a napkin ring constriction at the bifurcation. So probably that's what is the reason why one would have more of events with the Culotte technique. How could you modify the Culotte technique? Probably you could think about a DK mini Culotte technique. What do you do how would you modify this particular technique? Probably always try to think of an inverted Culotte, get the stent from the side branch into the main vessel first, then have a very mini overlap, less than 5 millimeter overlap, so that you have very less metal in the main vessel, and finally try to do a double kiss. That is, before you implant the main stent in the LED, you could always do a balloon dilatation, and this was the publication on this particular DK double Culotte. This was a patient who presented with an with a lateral wall myocardial infarction, had a occlusion of a huge diagonal branch. Those are the images. You could see that there is some haziness at the D1 which was occluded. That is what is how the LED looks like. We wired the LED D1, did a balloon dilatation of the LED diagonal ostium. You could see that it's a huge diagonal branch. It's almost a 3 millimeter diagonal. So we decided on a Culotte technique. We decided on a DK mini Culotte technique. You could see the stent being positioned in such a way that it's hardly less than 5 millimeters protruding into the main vessel. The stent was deployed. Once the stent was deployed, we did a pot, and once we did the pot, we recrossed through the distal cells into the main left anterior descending artery. Again, an OCT was done. The distal crossing was confirmed. The overlap length was hardly 5 millimeter inside less than 5 millimeter inside the main vessel. We also made out that we also did a first kissing balloon dilatation. The stent was deployed, repot was done, and again recrossed into the side branch. Second kiss was done, a third pot was done, and that was the final result. Well, the understanding, you could achieve a good result. So finally, at the end of the day, what we could achieve by doing a DK Culotte would be, you could see a wide looking confluence over here. It's not there is no constriction over here at the confluence. It's a wide looking confluence, and even the diagonal branch is looking great, and that is what this trial says. Well, to conclude, dear friends, OCT in non-left main bifurcation lesions, it's useful in evaluating the lesion. You could do the MLD, that's morphology, length and diameter assessment. You could also have a look at the bifurcation. You could assess the predictors of side branch compromise during the main vessel stenting. And finally, once the stenting is done, you could also go ahead with further optimization based on the MAX criteria. That's look at the medial dissection, whether you have proper position of the stent, whether the stent is well expanded, and also you could evaluate the carina and the confluence. Thank you once again for the patient here.
Thank you very much, Dr. Deepak, for that very enlightening talk on imaging in bifurcation. Very fantastic cases which outlined step-by-step procedure of how to proceed with imaging. We'll get some insights from our course director, Professor Bahuleyan sir, on this particular
yeah, again, as usual, Deepak, very fantastic talk covering all the aspects of imaging and bifurcation. He started with the usage of MLD Max again in a bifurcation lesion when you use OCT. He then shifted to the plaque identification and morphology and plaque modification, need of plaque modification based on the OCT findings. Even strategy, whether it is provisional or a two-stent strategy, looking at the side branch, the branching angle, as well as the carina tip to the branching point length, all these things that he had covered. and finally getting a good result. The whole idea, apart from the non-bifurcation lesions using a OCT, is we will have a better delineation of the anatomy, pre-procedural anatomy of the bifurcation. That is the greatest advantage. And that gives you an insight into what way you should forward and achieve a good result, and finally ensure by OCT the good result. Another important thing is that the wire crossing, the stent struts, he has emphasized it very well. And of course, many people try to look at it. We have discussed it during Mathu's case about whether it is really required all the time. We will continue to look forward more evidences that it should be looked or not, but that's a point in bifurcation. One thing which I wanted to highlight is that many a time we have to put more stress on the plaque morphology at the bifurcation, because calcium at the bifurcation is quite common. And many a time it will be sometimes calcific nodules. So calcium quantification and the modification.
Recording in progress.
Very important.
Recording stopped.
OCT is usually helpful from that point of view. Thank you, Deepak. Very nice coverage of the topic, and you have clarified many points.
Indeed, that was Dr. Elvin Kedi just left us. He said he had to leave. Those were very fantastic points. Anybody from our expert panel who would like to share their insights on Dr. Deepak's talk?
Thank you, Dr. Deepak, for a very nice, elegant talk for conceptual understanding with image-guided bifurcation. Only one question, actually, if connectors are there in the bifurcation, can we upsize the balloon 1/4 to crush that this one, or is it not feasible at the bifurcation angle? Any experience of you? I'm asking because I have less experience in this.
No, I'm not very sure about this. What the data says is when you have these sort of links at the bifurcation, when you have a linked bifurcation, then following kissing balloon dilatation, ultimately you end up having some amount of struts which is not well opposed to the vessel wall. But I'm not sure whether you have data to go upsize the balloon so that you have a better stent opposition at the bifurcation.
Thank you.
I have one question. Supposing, as usual, you rocked with your presentation. So for ordinary mortals like us who do single stent, I wanted to ask, supposing there is no link across the ostium on OCT, just don't do anything. Could that be a strategy in the single stent strategy? Just do nothing to the side branch.
Yes, ma'am. As any other interventional cardiologist would want to do, get the procedure done as quick as possible, safe as possible. Try to avoid multiple balloon dilatation. Even I would also want to do that. So in the past, we all learned that unless you wouldn't have to do a kissing balloon dilatation when you do a crossover stenting. But nowadays, we hear people saying more and more that when it comes to a left main bifurcation, we would always try to do a kissing balloon dilatation just to keep the circumflex osteo open. But with the usage of OCT, I would also prefer when there is multiple struts over the bifurcation, then probably a balloon dilatation, kissing balloon dilatation would be useful. If you do not have significant struts or a linked cannula, then probably one should leave it. We do not have a lot of data regarding that.
Dr. Rajpal here, cardiologist from Bangalore. Excellent talk.
Dr. Rajpal.
Yes, Dr. Rajpal.
Excellent talk. And I think the practical things are very highlighted. This is probably one area in the current age and of stenting that we should be using OCT, because the bifurcation lesions definitely would benefit, particularly if you're using a two-stent strategy. I think one of the other things that needs to be highlighted is the amount of contrast load that's involved with doing OCT in bifurcation lesions. So what's your views about when do you actually have a run pre-stenting and post-stenting, or do you do it for every time you cross over to the side branch, you get the morphology, and then take a run as well?
When we do these sort of difficult cases, we always try to do in between shoots also, OCT runs also, but then we would always try to reduce the amount of contrast. Many times you would always want to, when you do a pre and post imaging, you would always want to have 14 to 15 ml of contrast during the run. But then when you want to look precisely at the bifurcation, we would keep the lens just beyond the bifurcation, keep the contrast load to a minimum. That's around, we keep it at around 9 9 or 8 ml contrast, so that you just get an information regarding the bifurcation alone, not the most distal, not the most proximal, so that you could limit the amount of contrast also being used. And we would also prefer using the manual mode of triggering rather than going for an automatic trigger mode.
Thank you very much, Dr. Dew. I think we will wrap up this session. We had a very fantastic discussion and talks there. Thank you, Dr. Deepak, for the talk. Thank you, Dr. Elvin Kedi, who has just left us. Thank you, all our expert panelists, Dr. Sujata, Dr. Kaparthi, Dr. Rajpal Singh, Dr. Umeshan, and Professor Shiva Prasad, sir, for this fantastic talk. Thank you, and we'll be moving on to the last and final session of this particular day, imaging in different scenarios. For this, before we start off, our live case, Dr. Madhu just mentioned that he finished his procedure, and he would like to show us, explain, Dr. Madhu, what we did with that side branch there.
Hi. Can you see the screen, the angio?
We can, yes, exactly.
Yes, right. This is where we left you.
Exactly.
So this is what we did. We did put a 2.5 into 12 signs. This is a mini crush with a 3.5 balloon within the LAD. There's a stent being deployed. And it is post-dilated to high pressures. Then it is crushed with a 3.5. This is after that, just to make sure that it's fully crushed. Otherwise, you know, the wire can go in between the layers of the stent. And then it is crossed, dilated with a 2.5 balloon at high pressures, followed by a kissing balloon. It's a 3 and a 3.5 alternatively at high pressures, followed by both together at normal pressures. And there's a report, and this is the final result. And we have the OCT now. Can you show the OCT, please? There's a OCT which showed a well-deployed stain. There was no dissection anywhere. The bifurcation is well open, and the overall expansion is 93%. Show the bifurcation view. Yes, so that's where we have.
I think that's a fantastic result there.
Perfect results, actually. Dr. Madhu, the first pot balloon was 4 millimeter, right?
Yes.
Okay.
It's a 4 into 8.
So for first crash, would you? Why did you choose a 3.5, or you wanted to see how you planned a sequential crash?
No, we used a 4 balloon because it is the lumen was really around 3.3. We used a 4 because if you look proximally into the LAD, where we had an EL, it is around 4 there.
Yeah.
So based on that, we took a 4 balloon.
Okay.
And we took a 3.5 because the EL distally was only around 3.2.
Okay.
So we couldn't take a 4 distally, so we took a 3.5 and went to high pressures. And the 4 was at 9 atmospheres at normal pressures, just to open the stent struts into the diagonal.
Okay.
Fantastic there.
Great
I
results,
think
actually.
one point, Dr. Madhu, one problem of not seeing the EL to EL in the proximal segment in the MLD max is this one. Actually choosing 4, there is some degree of assumption is there. It is 3.3 lumen. If you add on 0.25, then it becomes 3.5 millimeter stent for the port or the proximal dilatation. But we are not sure how much is the plaque, how much is the size of the vessel. Easily, sometimes the proximal vessel may be 4. So there is some assumption at that point. So the lack of EL in the proximal segment. Distal, of course, you can manage because you can go by the lumen diameter or a little higher size stent and deploy it at a lower pressure. But the proximal dilatation becomes difficult, especially in the absence of EL to EL.
Yeah.
Bahuleyan, sir, just a quick question, sir. Sir, if you were to do this final steps in this particular case, would you have opted for this strategy, the crushing strategy, or would you have opted for a more simpler strategy, just a tap at the diagonal?
Yeah, despite the angle being very narrow, in this particular case, I would have opted for a tap technique.
Now, the only reason why I didn't use a tap was if you use a tap, it would be quite a large segment of the neocarina inside, in between. So I was really not comfortable, but so much of stent jutting into the lumen, which is why it was a mini crush. Especially with an acute ankle, you would have to pull back quite a lot. That is the only reason. Otherwise, tap.
I think that was a great case for learning, especially the point that a dedicated OCT of the side branch after the main stenting, which showed that a significant dissection was present at the ostium, which led us to taking up the two-stent strategy here. I think that was a fantastic case there by Dr. Madhu. A lot of learning points through image-based PTCA. Thank you very much there.
Thanks, Shafeeq. Thanks, Salman. Thanks, Team Abbott.
Fantastic.
Yeah, I think Dr. Madhu, please continue in the next session.
We go on to the next session, imaging different scenarios. Dr. Madhu will retain his position as an expert panelist. Along with Dr. Madhu, the expert panelists to join us are, we have Dr. Sajan Narayan, Senior Consultant at Little Flower Hospital, Angamali, Dr. Rifai Shaukat Ali from Apollo Hospital, Chennai, and we have Dr. Ajay Swami from the Command Hospital, Bangalore. A very warm welcome to you from the ICS team here, to all the expert panelists here. And the next topic, the penultimate session here, is OCT in the ACS scenario. To give insight on this particular topic, we have with us Dr. Selvamani Seduraman, Senior Interventional Cardiologist from Madurai, Meenakshi Mission Hospital, a very senior expertise, person with vast experience in OCT and IVUS guided imaging PCI. Over to you, Dr. Selvamani. I think you're muted, Doctor.
Yeah, thank you very much for the opportunity. It's a pleasure being with you there. And I thank Dr. Bahuleyan, Shafeeq, Salman, all of you there for a wonderful meet there. So without wasting time, today I will just go to this topic per se, imaging or OCT in acute coronary syndromes. See, basically, when you look at the causes for acute coronary syndrome, these are the important points that you should remember. Predominantly plaque rupture, calcific nodule, erosion, and of course, very rarely tight stenosis, dissection, spasms, fissures, SCAD, and recanalized thrombus. These are all some of the very rare causes. But the most common cause is rupture and then erosion, and comes probably the calcific nodule. So, what is the importance of knowing this causes? Most of the time, treatment also varies on that. So, how to make out, just with an angiogram, it's really difficult. You cannot make out all this pathophysiology of ACS. You definitely need OCT to make out the precise differentiation of this pathology. Look at this patient here. He had an inferior wall MI and then he was thrombolized. And angio shows like this. It's a very simple, straightforward lesion. And we generally tend to just put a stent there. But when you see an OCT, you can clearly demonstrate what is happening there. There is a clear area of rupture you saw there. And see, this is the area where it's a clear rupture, and then there is a narrowed lumen, which has caused the problem. Along with that, you see signs of inflammation, which we have been discussing in the previous sessions also. Cholesterol crystals, macrophages, microvessels, everything seen there in that image. And then, of course, straightforward stenting with excellent result. And coming to the next case here, again an inferior wall MI thrombolized. You have an angio like this. So there is something like a thrombus. You can definitely say it's a thrombus there. And to know the exact reason, like you want to stent it or just leave it, it's always a controversy. So look at the OCT. What we are seeing here is there is an area of rupture. There are some thrombus there, and it's a good lumen. So generally, if it's a very good lumen like this, although if there is a rupture, you need not stent these patients. So generally today, the criteria is if the lumen area is more than 2.5 or it's somewhere around 2.75, it varies from the recommendations, then you need not stent that area even if there is a rupture. But any lumen area less than 2.5, more specifically if it is less than 2 or 1.9, especially like in erosion trial, probably you'll have to stent it. Otherwise, you can just leave it. Look at this. This is an example, again, an anterior wall MI, thrombolyzed patient. And angio looks like it's a recanalized LAD. This is what generally we say. And look at the OCT. Here it shows some irregular areas, which we call it as probably that's an erosion there. And there was no areas to represent any rupture. It was all thrombus, and then it was all irregular areas. So this is an erosion with a very good lumen. So the patient requires nothing, just medical management. Probably if it's a huge thrombus, nowadays we put some antithrombotic drugs for a month or two, depending on the amount of burden of thrombus there. So you can defer stenting in many cases of ACS, especially young patients and especially smokers. This is a possibility. And coming to a classic anterior wall MI here, we had an MI. I have done a thrombosection here, and this is the angiogram after thrombosection. It's a clear diffuse disease here. We really don't know where to land it. So look at the OCT here. What is happening here is you have an area of rupture, and you know that distal vessel is diseased. We are not getting a normal area, even in the distal part. But anyhow, try to get an area where there is at least less than 50% plaque burden, and look at the vessel there. And this is the proximal landing, and then we know the proximal EL there. So now the exact anatomy is defined now. Although it is diffused area, we can select an area, a distal landing zone, where there is probably a plaque burden which is less than 50%. So this is how you measure. So if you get an area where the plaque burden is less than 50, probably you can select that area to land your stent there. And coming to the proximal, I then deployed the stent. Post-stent, many times in an ACS, you get something like this. This is what we call it as prolapse. So generally, if the amount of prolapse is so much, you can just leave it. Many times, if it is more than this, like it's more than 20%, if it is associated with under expansion, or if it is associated with TIMI-3 flow, less than TIMI-3 flow, probably you'll have to dilate it with another balloon, prolonged dilatation. Very rarely, we might have to put a second stent if it is a significant prolapse with slow flow, and then if it's a very important vessel, probably we should do that. But otherwise, most of the time, you can just leave it like that. So coming to another interesting case here, this patient again was anterior, recently I did this, anterior wall MI thrombolized. And you look at the angiogram here, what you are seeing is anterior wall MI thrombolized patient. There is a lesion here, there's a lesion here, there is something like a thrombus in the proximal segment. So what to do in such a case here? Now look at the ECG. So here ECG before the thrombolysis clearly shows there's an ST elevation, there's elevation in the lateral leads also, indicating probably the plaque, the occlusion was above the first diagonal. So when you see the angiogram, like how to correlate, like probably the culprit area is here, but angiographically it has recanalized, or there is something which we are not very sure what is happening. But there is a lesion down here. Most of my juniors, my fellows, they wanted to stent this area. So generally, that is not the way it goes. You'll have to assess, because the ECG was very, very useful to locate the culprit location. And then what happened is I did an OCT after 2 days. You look at the OCT, what is happening here is clear, you know, the plaque there, and then this is the area of interest, the angio co-registration you see here above the diagonal. When this marker comes above the diagonal, this is the area where the arrow area is significantly narrowed, and there is a big plaque rupture, big crater there, and the lumen there is very less. So this is what you are seeing there. It's a crater, ruptured plaque, and the lumen area is somewhere around 2 there. So in such a case, we just can't leave there, and there are some areas of healed plaque also there where you just can't leave it like that. So naturally, I stented that area. We did not do anything here. To take a decision so boldly without an OCT, I don't think we can do these things in our routine ACS practice. And with this, an excellent stent expansion and good deposition. And look at this angiogram here. A similar case, like some haziness, it looks like it's a thrombus in the LAD. OCT clearly shows it's not just a simple thrombus. It is a recanalized thrombus. And then you see that it's a lotus root appearance that which we get here. And then this patient was stented with excellent result. Many times we can do an FFR there that tends to be positive in all such cases where what we have done there. And similar case here, look at this again, something like a thrombus. And then again, this patient also had recanalized thrombus. What you can do is to decide whether this patient requires a stenting or not. If you cannot do an FFR there, you can look at calculate the effective lumen area here. You can calculate all the effective area. And if it is less than 2.5, probably you'll have to stent that area. So that is an advantage. Look at this spontaneous coronary artery dissection. Again, here there is a thrombus and there is nothing to there in the lumen when you do an OCT. But you see there is a small rupture where it has entered and then caused a hematoma there. Probably this case, we did not do anything. We just left him on medical management. Look at this case, again, an anterior wall MI. This patient had a significant calcified lesion with thrombus. And look at the nodule here. He had a very classical nodule projecting there. But anyhow, we could not do much there. We did not initially recognize that. But anyhow, we dilated with a balloon and then we stented this area. But the problem is there was significant underexpansion in this case. And then coming to a similar case where he had an anterior wall MI, but significant calcified lesion. I did a rota in this, although in acute ACS it is controversial, there was not much of thrombus. And on the rota, what you can make, I did is, there was a good shave off of the calcific nodule. This patient, he had a very good wire bias. How I make out on an IVUS, on an OCT is, see if this is the OCT catheter, if it is very near the calcific nodule, then it is a positive wire bias. Like probably if you use a rota in such case, you will have a good result in this calcific nodule. And he got a good shave off and then an excellent stent expansion was achieved. Coming to the current consensus document, intravascular imaging, especially OCT, is very, very important to know the etiology of ACS, and it helps in tailoring the therapy. There is no doubt. And OCT is the gold standard to make out thrombus. There is no doubt in that. Of course, we have a lot of recommendations and advantages of that. Understanding the mechanism, looking at the plaque rupture, which I already showed you. These are the common etiologies like fissure, spasm, nodule, rupture, erosions can be very clearly made out. And depending on that, we can decide the therapy also. We have an erosion trial where we have evidence to show that if it's only a plaque erosion, conservative therapy with antithrombotics without stenting does excellent rather than putting a stent in that patient. So to have a flow chart, whenever somebody has an ACS, if it's an obstructive CAD, if the culprit is very clear, then probably you can go ahead. But many times when there is an ambiguity, you do an imaging, like especially OCT, which gives you the etiology and then you take a decision. Very rarely it can be a normal coronary, but it will be very, very useful to say that this patient does not require any treatment depending on the OCT findings. And on this, generally what we do is, if there is a plaque rupture and a reduced lumen, you stent it, calcific nodule, you stent it, erosion, you defer, and all these things, depending on case by case, you decide. Most of the RCTs or recanalized thrombus needs stenting. SCAD can be left on medical management. So you decide your therapy on OCT. And one important question, a lot of my friends and a lot of my doctors ask is, will you do OCT in all ACS? Yes, probably in most of my cases I do. There is an exception. Like if a patient is hemodynamically unstable, pulmonary edema, shock, then of course we can't do it. Huge thrombotic burden, if I am worried about the distal embolization and slow flow, I don't do it. And if already there is a significant slow flow, I am very, very concerned about it. And of course, as you know, like renal failure is a problem. Saline is excellent in right coronary arteries. Left, probably you'll have to put an extension catheter and try. Thank you very much for the patient listening and for the opportunity.
Thank you so much, Dr. Selvamani. That was a very interesting talk. It's a new area where we can apply this application of imaging in acute coronary syndrome not so unstable patient. So let's see what our panelists have to discuss about. Dr. Madhu, would you like to comment on this chances of OCT? Would you like to do OCT in all MI? That's the question.
It's an excellent talk, Salomani, but as you are saying, when you find an ambiguous lesion and you do an OCT, now, how sure are you about the physiological significance of it?
Yeah, yes, Madhu, it is always there. See, for example, if you really want to do a physiology, you cannot do it in an acute STEMI. You'll have to wait at least for a week. So in such a condition, how do you take a decision whether you are going to stent it or not is imaging. And then basically you look at the lumen diameter. If the lumen diameter is 3.54, I think then you need not worry at all. If the lumen is less, probably 2.5 or less, and then you see a lot of signs of inflammation, you have a huge ruptured plaque. Nearby, you're seeing a lot of macrophages, again, some yield plaque if it is somewhere nearby. I think you should go ahead and stent it. Again,
what cutoff of MLA would you take, Salomani, roughly?
Yeah, but there are a few trials like Forza trial, which they have taken as 2.5. And erosion trial, they've taken it as 1.95. It varies from at least from 1.9 to 2.5 is reasonable. That is what we should do.
Great. Dr. Sarjan, do you have any insights to offer on this
interesting topic? Just I may sound a little weird also. See, you were advising that in the case of a rupture and MLA is more than 2.5, you may defer stenting, because classically the benefit of stenting is to prevent reocclusion. From the days when the stents were discovered, the actual benefit of stenting is in the prevention of re-MI and reocclusion. So how safe are you in deferring just based on a luminal area of 2.5 in the case of rupture? How safe it is to defer stenting in such cases?
See, as of today, we don't have evidence to say that if we're looking at the thin cap atheroma or a rupture, you need to stent that lesion. Today's our criteria is basically you look at the lumen diameter. As Madhu clearly said, it's a physiological guided. And we have a correlation. Probably if a lesion is less than 2.5, it's going to be FFR positive. And since we cannot do an FFR in this circumstance, this is how you should proceed. That is what evidence we have. Your point is well taken. Rupture is a problem. But if the lumen is very big, leaving a rupture doesn't really affect his long-term outcome. That is what is the evidence today. We really don't have an evidence to stent a vessel where the lumen area is very big. Just looking at the morphology, you cannot stent it. Probably you can put them on very high dose statins, just follow them up. That is what we have to do.
Dr. Rifai, how often you do OCT imaging in acute MI scenarios?
Yeah, I think there is, as Dr. Selvani mentioned, there are specific criteria. I don't do OCT in all acute MI patients, firstly, for various reasons, we all know. But the most important reasons I do ACS OCT is in young patients. I think that's probably where the most important aspect is it. If anything above age of 50 and we're coming in with an acute MI, typical ACS risk factors, I'm not sure how much benefit apart from your optimization of the stents. Whereas in young patients where particularly you want to defer stenting, like what I had is a 23-year-old young guy who came with an acute MI and I had a plaque erosion with an area of more than 2.6. So I left him alone, but I shoot his coronaries again as well. So in those kind of situations where you may think that there is a possibility of plaque rupture is a little controversial in the way that how you treat plaque rupture. I agree, plaque erosion, we can definitely, with a bigger lumen area, we can wait. But plaque rupture, remember, we know that in 100% of our AMI, 40% is plaque rupture, 40% is plaque erosion, 20% calcific nodule. So if you are saying that in both plaque rupture and plaque erosion, we're going to put stent, then 80% of your patients, you're not going to stent. So I would say in plaque erosion, if you have a bigger lumen, I will definitely, in a young patients, I would rather wait and see. But in plaque rupture, I am still skeptical about leaving it as it is. But in those kind of situations where I think there may be a possibility of deferring the stent, or there may be optimization needs to be done in a proper way, like if you have an elderly man where you have a calcific lesion, you want to get it properly, then I would do an OCT situation on that.
Yes, indeed, very exciting concept there. The retention of the fibrous cap, having the fibrous cap in an erosion probably protects you, and losing the fibrous cap as in a rupture might be unstable, as in the study mentioned there. Professor Bahuleyan, sir, any closing remarks on this session, on your insights on this particular concept there?
I think the message Dr. Selvamani wants to convey was, not only the aspects of, questionable lesions of vulnerable plaque plus lumen reduced or not, what you call as intermediate or non-culpable lesion. He was highlighting that in the lesions which are going to treat, use imaging so that, we'll get better results. So more and more acute coronary syndromes have to be viewed as what you are treating in chronic stable lesions. You use imaging and try to optimize the results as much as possible. And he's telling that there is evidences are emerging that use of imaging in acute coronary syndrome, if possible. He has shown instances where you will not use. If a hemodynamically unstable patient, thrombus burden, no reflow, don't use. But other cases where if the patient is stable and you want to have a good result, especially long lesions, bifurcation lesions, calcified lesions, how he has done an OCT in a particular patient, only imaging helped him, gave him the confidence to do that. Unless you use OCT, the rotablator in that particular case, the stent would have been underexpanded. So it is very, very important. Nowadays, many people feel that just stent, get the flow and get out of the lab. I think we should move away from that, at least in vast majority of non-ST elevation MI and the selected cases of STEMI. That's the practice which I started using. Especially when you have to place a long stent from the ostium LAD down into the mid LAD, you want to be sure that your stenting was perfect and not getting into the left main and what not. So I think it is a time when we are trying to use imaging in our patients with acute coronary syndrome. Thank you, Selvamani, for conveying that message. If I am correct, that's what you wanted to convey?
Yeah, excellent, Jai. That is what we are focusing. And this very small, see the subset where there is a rupture and then block, the lumen area is very big. That percentage will not be very high. It's a very small percentage. Most of the patients, they'll have a ruptured block, lumen is going to be narrow. We are going to stent it. But why I highlighted it is, even today, we don't have an evidence to stent a vessel without lumen narrowing, just looking at the rupture. Yeah. So if it is a narrowed lumen, then it's acceptable. So we don't have evidence. Absolutely. Yeah, absolutely. We don't have evidence to just stent all ruptured block or thin cap or trauma. We don't have evidence for that.
That's
probably. If I may ask you, Dr. Selvamani, just quickly, what do you think about the role of antiplatelets? Do you think, would you consider, if you have a patient with a plaque rupture who never had been exposed to an antiplatelets, would you consider them that they may be safe, you're starting antiplatelets? Or would you consider that somebody who's on antiplatelets and coming with a plaque rupture, would you reconsider your situation, having seen that the gentleman is already, or whatever, the patient is already on antiplatelets, now we're going to leave this alone? Will that have an impact on your decision making? I'm just interested to see how the panelists, other panelists thinks as well.
Yeah, it's a very new thinking. And then we really say same even here, considering a NOVAC or an anticoagulant, we don't have an evidence, especially for acute coronary syndrome, just looking at the thrombotic burden in the vessel. It's in your own discretion. Like, you will have to look at the bleeding risk of the patient. Like if he's a very high risk bleeding person, I don't think I will add an anticoagulant for it. And if it's a very young fellow, I think if the bleeding risk is very less and a huge thrombus, I generally put them on triple drug for 1 month and then make it as 2 drugs. So that is a possibility. It varies from an individual to individual. Very difficult to generalize as of today, but the main thing is look at the bleeding risk and then take a decision.
Fantastic point.
The issue of sorry. Yeah, sure. The issue of plaque rupture is, you can have multiple plaque ruptures in the same vessel. So so you can't keep stenting everything. So it's unless
that's it. Yeah. See, many times what we see is in a vessel, if there is an MI, we'll see plaque ruptures, healed ruptures in 2-3 areas, and then acute rupture in some area. So all those findings are very common. So unless there is a lumen narrowing, we cannot stent it.
Probably one of the new things coming up is in acute coronary syndrome and OCT. You don't find much lesions, but thrombus more and large vessels, and not stent is left. Instead of dual antiplatelet, probably one could think of dual pathway inhibitions like oral anticoagulant plus one antiplatelet, especially Novak, maybe a useful situation to consider in such patients. We have put patients like that recently, especially now we find younger patients coming with acute coronary syndrome. We plan to do at least 6 months down another angiogram. What's the resolution of the thrombus?
Fantastic, fantastic.
I think we have Salman.
Yes, we're going for the last talk, sir, of this session, of today's imaging session. For that, we imaging in LMCA lesions, OCT versus IVUS. IVUS is a neglected modality for today. So I think to give justice to that, we have Dr. P.K. Sahu, Senior Consultant Interventional Cardiologist from Apollo Hospital, Bhubaneswar, who carries with him a vast experience in imaging-guided OCT and IVUS-guided PCI. Over to you, Dr. Sahu, for taking over this talk.
Good evening, everybody. In fact, thank you very much for inviting me to give this talk. Thank you, Professor Bahuleyan and all the organizers. In fact, it's a fag end of the first day, and I think everyone was tired hearing about imaging. But a very difficult topic about OCT versus IVUS in LMCA. When we do a stenting, the first thing we think of is be precise. A lack of precision is dangerous when the margin of error is small. This is what happens when we do stenting. Because of a little bit of error, the danger starts. I'm not going to start a fight between IVUS and OCT. Basically, I'll try to finally give my opinion about where IVUS stands and where OCT stands in left vein disease. Now, we know that left vein is a very complex subject. In fact, 50% of these cases are calcified, distal left vein lesion in 70%, and concomitant multiple vessel disease in almost more than 70%. And what we have seen in angiography is just a shadow world and is completely different. As you see these two ladies walking, but it looks like a gorilla there. It's much different when you go to IVUS and this thing. This is what an angio shows you. This is what an IVUS and OCT show you. For a common thing that we have to know that it reveals more than what we see. Now, the first question that I'd like to answer is, does IVUS-guided PCI and LMCA make a difference? Let us see. The main compare studies first showed that definitely it causes a significant lower 3-year incidence of mortality. As you see, at the end of 3 years, those who underwent an IVUS-guided LMCA, they had lesser mortality. This was one of the first studies, or the early studies on LMCA and IVUS. Then if you come to the 2020, the Euro intervention, where the Noble trial sub-study put about IVUS in left vein STEMI interventions, left vein STEM intervention, clearly stated that there is an association to reduce left vein stenting target lesion revascularization. So the use of coronary imaging to prevent stent underexpansion and LMS PCI is likely to improve outcomes. So this is the message that should go, that definitely if you used IVUS, the 5-year MACE was less. If you use IVUS, the 5-year target level revascularization less. And most importantly, if you achieve your target area more than 13, there was hardly any 5-year LMS, target level vessel revascularization. So this is some important data from the Noble study group, which has been published in 2020. The same data, the 5 years outcome clearly stated that whether you consider the major adverse cardiac events or the LMS TLR or the non-procedural MI or the repeat vascularization, all were less. And thus the conclusion into daily practice was that adequate lesion preparation and stent optimization is most important in left vein stenting. And that is the main reason why you use IVUS. Also, it was put regarding the outcomes of predefined optimization criteria for IVUS guidance. We know that IVUS is one of the gold standards that one has to use in doing left vein stenting. We know what are the expansion, whether it's an ostium, it's a shaft, or it's a bifurcation. We have to optimize it and what phase we have doing it. And most important, provides a prognostic value so far as the long-term outcomes are required. Now, impact in daily practice, it prognosticates, and that outcome will always be better. Now it improves the prognosis. Now what I consider as the best utility of IVUS in left band is when you have a borderline left band, you have an ostial left band, and of course the soft and the distal LMCA you can use either of the modality. Now, when doing a left band, we should know in precision stenting, numerical precision is very soul of science in left band. Because, for example, if you have borderline left band like this, 50% stenosis, we are all confused about what to do, whether the angiogram is sufficient, or I do further an anatomical study, or a physiological study. You'll be surprised that for borderline lesion, what has been recommended that LMCA is one of the most ideal choice of imaging that has to be done, rather or an FFR, where it is more ideal, and finally decide whether it is a borderline lesion that needs to be tackled or not. This was a study which clearly stated after an angio, if you have a borderline lesion, you have to do further invasive studies, either an IVUS or an FFR. And this was published way back in 2011, which gave us insight for a very small population that definitely IVUS was important. Now, how does IVUS help in borderline LMCA? If you take the runs from LMCA to LCX or the LAD to LM, if you see your distal LMCA, the plaque burden is high, the MLA is low, then definitely these are the cases where you have to intervene. But most importantly, what was said as per the Mayo Clinic experience, that if you have anything that is less than the cutoff area for the ROC was 9.6, and if it was less than 7.5, you have to revascularize, and if it is more than 7.5, you can defer it or revascularize based on the clinical symptoms. There was a litro study which clearly stated that those who were having a MLA of more than 6, it is better to defer them. These are been different populations, and they were quite old studies, and as we have come in 2021, naturally studies do say that we have to achieve much better areas, and those who had point less than 6, it was better to defer them. So what we stand today is that if as we go to more than 6, it is better to defer it, and if it is the symptoms are not there, non-invasive tests are not significant, we treat the patient and do not treat the numbers. So we have to see whether it's a diabetic and what is the size of the vessel, whether there's a TICFA, whether there's a positive remodeling is there or not, and whether the body size is less. So based on the body size, the figures started coming in that if there's small population, you have to achieve these figures of 5, 6, 7, and 8. This is especially for our Asian population. And for the Excel criteria in the other populations, it was something higher, the 6, 7, 9, and 10. This is to be noted. Now, one thing, what do we do in borderline LMCA? This is something we know all about the plaque characteristics, the luminal area, the lesion length, but this is where we miss the ostium. So this is where IVUS scores over OCT. Now, just to establish few cases and to show how it helps, there's a critical tight LMCA ostial lesion here, and the stenting has been done, and you can see just a single stent, and you can see the area from the pre to the post testing, how well it is expanded, and the area is finally very significant. Coming to another case of LMCA where there's a soft and distal lesion, where I planned a provisional stenting. You can see the plaque area of the LMCA is very fibrofatty plaque is there. The area is less, and naturally you have to go for a stenting in this case. And that is what was done. The post-stenting results does so that we have achieved a good area, and the angiographic results are very good. Now, coming to a soft and distal lesion where possibly you have a lesion from left main to LAD, left main to circ, and a very tight lesion where the ostium is free. Here you have to do a DK crush, and going by DK crush, if you do follow all the steps, and ultimately you can see the LAD and the circ, whether they've achieved the right area, and the left main is definitely good. So IVUS definitely is of a lot of help in left main, whether it's the ostium, the soft, or the distal bifurcation. But then if you try to go further, let us see what happens in cases of trifurcations. In trifurcations also, if you see, if you have multiple lesions in all the 3 arteries, if you do this thing, trifurcation lesion where you do 2 kissings, and then you see that definitely IVUS does help in these cases. And most important in these complex procedures where you have to use less of contrast, possibly you have to use imaging modality where the contrast use is less. Now, let us see how OCT scores of IVUS in left main disease, basically plaque erosion and rupture. Already Dr. Selvamani has discussed in details about the bifurcation angle, the BPCT length. Dr. Deepak was already establishing and was showing in his cases about a single and double stents. Calcium quantification is something that's very important. Malapposition is something which you detect very quickly and very easily on an OCT, and most importantly, to detect any complications in left main if it involves shaft or the bifurcation, OCT is useful. Now, for example, I need not show this diagram because this has been dealt in details by Dr. Selvamani. And let us take a case where there's a left main DK crush has been done, a distal lesion, and this is the pre and the post. Here I did both the IVUS and the OCT. It was definitely well established that both the modalities were helpful. So whenever you're doing a distal lesion, both can help you in establishing whether your stent has opposed, your stent has not opposed, then you have to do further. But most important is the side branch opening, which you cannot know in an IVUS. The side branch can be clearly seen if you do a OCT run and do a rendered view and see how your side branch is opened and whether there are any struts. Now, this is a LMCA to LAD lesion where a single stent strategy has been used, and you can see a tight lesion. And what we saw was that when we took an OCT in this case, most surprisingly, what we saw was the struts had not opposed in the left main. And this is something where we don't want to leave the case, and OCT does help. I do not disagree with the fact that if you're a good user of IVUS, you can also see the malapposition, the criteria is there, but in OCT, it is very easy to recognize this. And then you can again do a good pot and see that the struts have all opposed properly. Coming to your next case, where it helps very much, for example, when you have a complication, this was in another center where the patient had just a mid-LAD lesion, the stenting was done, but finally there was a problem, and they had caused a dissection of the left main, and it was not sure how far the dissection was, and this is where we have to use definitely an OCT to see. This patient was shifted to my center, and then I had to put a second stent to show that definitely we had done a good job. You can see how bad the dissection is, and this dissection was a guide catheter used dissection, and I had to put a second stent, and you can see clearly, you can see that the stent there was definitely a big dissection which had to be put, a stent had to be put, we had to be in the true lumen, and finally it had to be opposed. And this was the final result when a 5mm stent had to be put, a kissing balloon was done, and this was the final result. And as you can see just on a stent boost also, that both the stents are well expanded and the final result is good. So this is another area where you can know that if you have caused a complication, possibly an OCT can help you to know what is good and whether you have done the job rightly or not. This is the final OCT pictures which shows that the stent has been well opposed and the results are good. Calcium is something where we all have known that we know how to quantify the calcium, and based on the calcium modification, we can know what type of modality we have to use. But if I have to summarize my talk, if I see the left main, it has got the ostium, the body, and the bifurcation. If I have to treat the ostium, I always like to go for the IVUS, and if I have to treat the body and the bifurcation, I'd like to go for the OCT. To conclude, I would like to compare the IVUS and the OCT left main. So far as stent sizing and optimization, both are equivalent. Whether to have a ruptured plaque or thrombus, the OCT has a superior edge. Left main lesions, definitely IVUS has an edge because it can quantify both the ostium, the body, this thing bifurcation also. Out ostial lesions, IVUS is definitely better. CTOs, IVUS is better. In-stent restenosis, OCT is better. Renal dysfunction, IVUS is better. Calcium, OCT is better. So each modality has its own position. No one can beat anything. We are not here to debate today, but to know where we position which. And in fact, in many of my cases, I do both an IVUS and OCT to be very sure about what's going wrong. This is just my conclusion and a last message that intracoronary imaging are like the glasses for the modern interventional cardiologists who do not like to take blind decisions. If you are like this lady who's crossing the river, With blindfolded, she doesn't know where she'll land in problem, where she'll get drowned. So you have to use some form of imaging your left main disease so that you finally have a good result. Thank you very much for the patient hearing.
Thank you very much, Dr. Sauda. Fantastic talk, great insights into differential usage of IVUS versus OCT. Great take-home messages there. Obviously of great benefit to all our persons who have logged in today. We'll get our views from our expert panelists. Dr. Sarjan, any comments on the talk just mentioned here?
Yeah, excellent summarize of all the data report. Just one question which I thought may be relevant. In cases of borderline left main MLAs, for example, if you get an MLA with IVUS, say 5 mm squared, in a fairly well-sized individual, whether a plaque burden will influence your decision to defer or to, suppose you have an FFR which has come as 0.81, and whether a plaque burden will solely influence your decision in deferring or to rule in such cases. What's your experience?
See, what I usually do is, I don't go only by the plaque burden or the area. Please look into what these clinical symptoms are also. And you have to see mainly, are not treating numbers, we're treating the patient as a whole. So you have to be a little bit judicious in knowing whether you really need to do, because you're going to intervene in a left main. So the lesser you intervene, the better it is. And the surgeons are always looking at you with eagle eyes to know whether you have really done the good job or not. They always come to your cath lab, see the angios the next day to see, and then they are a little bit, they are definitely, there are many people who are watching. So you have to be very clear about it. And at the same time, I don't want to miss this patient, and supposing I have a patient where the plaque burden is high, the patient is symptomatic, definitely I'll stent it.
Great. Dr. Shaukat Ali, you agree with those messages on the preferential use of IVUS versus OCT as mentioned?
Absolutely. I think it's a great talk, and I think it's well kind of put the message that when you want to use IVUS and when you want to use OCT. But just to add on to that, I think there have already been discussions about the use of telescope devices for ostial left main for OCTs, and in fact, I tried one of my cases. So I think that's also coming up. But at the moment, as you rightly said, the IVUS is the gold standard if it's going for an ostial left main. So the other important point I would like to mention, we talked about the Nobel and the Excel criteria of post-PCI optimization in the area. How far would you go? Say, for example, we mentioned 13, anything about 13 MSA, you have a 0 TLR rate at 5 years, which is probably the best you can get for somebody. But I mean, remember, I think that's one of the things we need to understand, that 13 for our patients is extremely low. We all know that. And sometimes, do you think that we try to do big and end up in complications? Or would you say that, listen, I'm getting about 9 or 8, I'm going to stop? What is your, I mean, is there any criteria you use? Say, for example, if you use a pre-PCI. So the one thing with the Lemon study in OCT is, it's not about the size as such, it's about the MLA reference area of more than 90% if you manage to achieve. In IVUS, unfortunately, we don't have that. We have only specific numbers for that. What is your thoughts on this particular aspect of IVUS and OCT?
A very important thing that you have raised. In fact, if you try to see that how much we should expand. Now, if you go by IVUS, there are 3 criteria for what you should expand. Do you want to be mildly aggressive? Do you want to be averagely aggressive, or do you want to be very aggressive? In fact, in left main, my take would be that you have to be very aggressive. You have to try to get the area which is the maximum. Next, you have to always see what is your stent expansion limits. That is the most important thing. You just cannot go on expanding the stent to whatever extent you want. Every stent has got a limit, and beyond which, if you try to expand it, you'll deform the stent. So these are certain 2 aspects that you have to consider. But definitely, as per studies, if you go to more than 13, it is definitely better. But sometimes before that, IVUS is to be used to do your plaque preparation. Your bed preparation is most important. Just without the bed preparation, the pre-IVUS is the most important. If you don't do bed preparation, your stent won't expand. So that is where the crux is. So using of imaging, the pre-imaging is more important than the post-imaging. So what I do in my practice in left main, sometimes I do a pre-IVUS and a post-OCT always. So that helps me the best way to know whether I have done the best job or not.
Great. Another related topic in this is the renal dysfunction issues, patients who
Yes.
have creatinine rise. So one topic, I don't know whether we've touched upon, the use of saline OCT. Dr. Madhu, would you like to just touch on this, your experience or insights as to how good or how easy it is to do a saline flush
I've
OCT?
not done too much of saline, but for RC, I think it's okay. But for left, I think it should be a contrast.
Bahuleyan sir would like to comment on this particular topic, I think, which is an important
We have tried it, but in the case of left main, where we wanted to have a very definite idea about malposition, stent expansion, and all that, I wouldn't dare to use a saline in that particular case. I will use a contrast. Limit the number of injections and use contrast and get best images.
Correct.
And I'm very happy that Dr. Sahu has made a very good appreciation of both the imaging modalities in the left main. I think you have touched almost all the points. But in my own practice, if you ask me, I use more of IVAS in left main, especially contrast. Reason is, the ease of use, multiple number of times you may have to use, and then no dye injection is required, especially when you have an ostial left main stent and the guide is there and you keep on injecting, it will be difficult. So I personally use that. But as you said correctly, for both the devices sometimes have to be used to be on to the surer side about the stent expansion or complications, especially the malposition and longitudinal compression of the ostial portion of the left main stent when it is extended with ostium. And thank you, Sahu, very much. Very nice presentation.
One last question to Dr. Selvamani. There was a question in the chat box. Whether persons with erosions can have a plaque rupture later on leading to ACS, something like a longitudinal progression from erosion to rupture. Do you have any comments on that? A question from the audience.
Muted. So please tell me.
So you're muted.
Yeah. Usually what happens is, if there is a rupture, when you look at the plaque morphology, you will see huge lipid burden there. And then that is where you see a lot of ruptures. In erosion, usually it's an younger group where the amount of lipid is not very high. And there is no, that is the intima is probably intact, where you just see some thrombus or irregularity in the lumen. But I've never seen that an erosion in future will become a rupture. Anybody can develop a rupture anytime, but I don't think any specific erosion is going to become a rupture. But as of today, what we see is, if there is an erosion and the lumen is adequate, then medical management is sufficient. For that, we have adequate evidence. You did not go and stent all STEMIs. That is what we are planning to say that.
Fantastic. I think we had a fantastic session. Thank you very much, Dr. P.K. Sahu, our expert panelists, Dr. Sarjan, Dr. Madhu, Dr. Selvamani, Dr. Shaukat Ali. I think we had a grand time, lots of interesting learning points, exciting points. I'd like to invite our course director, Professor Bahuleyan sir, to wrap up today's session, give us take-home messages on coronary imaging, on what we learned today and what our juniors should follow. Over to you, sir.
Yeah, thank you. And I think I say that it's a fantastic learning session. Thanks to Shafeeq and yourself for organizing this wonderful meeting, and all those who have given good lectures, and Dr. Madhu has shown an excellent case. And a lot of practical points have been covered. Most important thing from the talk is that, of course, we have touched upon the plaque characteristics starting from Jabir's talk, and then we have come to a conclusion that plaque characteristics and plaque morphology are something to should be looked into. And imaging certainly helps into that. Much more than that, the subset of stent failures, whether it's in-stent restenosis or stent thrombosis, many of times both of them may be combined in a given case. And imaging, especially OCT, gives a lot of insight into what are the mechanisms of stent failure in that particular patient, and that leads to a correct mode of treatment for that particular patient. That has been highlighted. And then, of course, the functional assessment alone may not be sufficient to select patients for revascularization, and more image characteristics, especially vulnerable characteristics like thin cap fibroatheroма and lipid plaque, lumen reduction, all are coming into into more clarity, and probably we may get more idea as to whether it should be treated with the stenting or just to give medical treatment. And finally, coming to acute coronary syndrome, Selvamani has given a nice overview of how we should be approaching acute coronary syndrome and how we should utilize imaging in that subset of patients for effective treatment, even with the long-term better outcomes. Dr. Sahu, wonderful. He has given his views, and that is most of us have accepted that his consensus on the use of imaging in left main OCT versus IVUS. Very, without any ambiguity, he has put both the devices in correct perspective in imaging left main diseases. Thank you very much. Thanks to all of you for contributing excellently to this wonderful session. And it was a great effort from Dr. Shafeeq and his team. And I congratulate him again now. And please continue this effort periodically. Thank you very much.
Thank you, sir, for the nice comments.
Thank you. Bye-bye, sir.
I hope we had a wonderful academic session covering various aspects in coronary imaging. I sincerely thank all speakers who's joined from various parts of the world, and all panelists who interacted and given their insights and made the discussions very lively and educative, and all the delegates for their participation. So tomorrow we are going to have more exciting topics in coronary interventions, starting at 6:30 with a lecture by Dr. Samuel Matthew on graft intervention, and then taking through the European Bifurcation Club, and then in the last session we'll be having futuristic interventions dealt by experts. So sessions start tomorrow at 6:25 p.m. and stay tuned. See you and good night.